There we go. Recording is now started.
Thank you. Good morning and welcome everybody to the public board of directors meeting for Northamptonshire Healthcare Foundation Trust. I'm Faisal Hussain. I'm the interim group chair for Northamptonshire and also Leicestershire Partnership Trust. So welcome to everybody and those colleagues who are also observing this. This board meeting is being recorded, so colleagues can also view this later on. And it's also being live streamed. Welcome to anybody who's observing, including our staff and governors. And also, I believe this is our first meeting with a big welcome to Sarah Willis as our Group Chief People Officer. Welcome, Sarah.
Thank you. Thank you.
And also, this is the first meeting, not the first meeting for Linda, but certainly the first meeting for Linda in a new role as Group Chief Nursing Officer and also Director for Allied Health Professionals and Quality. So welcome to Linda. I think she may be certainly joining us if she's not already here. Can't see her on my screen at the moment.
Good morning, Faisal. Good morning, everyone. I am here.
Oh, yeah. It's I've got too many screens, I think, Linda. That's what it is. Great to see you and welcome to everybody. So this morning we've got apologies for absence from Angela Hillary, our Chief Executive, but she's been deputised in the Chief Exec role by Dave Mayer, who's our Deputy Chief Executive and Managing Director. Also, we have apologies from Itai Matumbai, and he's being deputised by Sachin, who's our Deputy Medical Director. I know Sachin might have to drop off every now and again for urgent calls. So welcome to Sachin. In relation to any items on the agenda, are there any declarations anybody needs to make us aware? No, I'm going to give a few shakes. Okay, lovely, thank you. And then item 4, which is paper A in the packs, is the minutes of our previous meeting, which was held on the 25th of September this year, which is paper A. Everybody should have had a good opportunity to review the minutes. Are you happy in terms of the minutes accuracy? Julia?
Thanks, Faisal. Yeah, just one on page 5. Just to say that when I visited Brookview Ward, they'd been successful in securing some funding from the Royal College of Nursing, not the Nursing and Midwifery Council. Just thought I'd better put that as a correction. Thanks very much. Thank you.
Thank you very much. So we'll put that in as a correction and amend. Anything else in terms of accuracy? No? Can I take those minutes as a true and accurate account then? We can sign those off for our board minutes. Any matters arising out of the minutes that are not in our action sheet? No? Okay. And then we've got our actions sheet, which is paper B in the pack. And we've got the system-wide winter planning and risk. And then we've got that on the agenda for the private trust board later today. And therefore, with that in mind, are your colleagues happy to close that action off? Yeah, I'm getting some nods. Thank you very much. Wonderful. And then we've got the Board of Directors annual forward plan for the Trust Board. We're in line with everything that's there for your information. Anything that anybody needs to highlight from that paper? No? Okay, great. Thank you. And then we're into what I always find to be my most enjoyable part of this role, which is hearing our staff and service user stories about our care pathways, etc. I always find those incredibly informative and also incredibly engaging. So this is over, we're looking at the specialist and secured services, and I'll introduce our Chief Operating Officer. Anne, you're doing the introduction for this, I believe.
Yes, thank you, Faisal. So I'm really pleased that we're continuing our sort of series on reviewing the care delivery pathways. And this month, as Faisal said, it's the turn of specialist and secured. Unfortunately, Anthony Blades, the service director, was unable to be here today, but has been very instrumental in the making of this, what we're here to present. But Rachel Palethorpe, our assistant director in specialist and secured, has come to join us to talk about the overall pathway, but particularly focus down onto patient experience and sort of learning through working in secured environments. So I'll hand over to Rachel and to take us through the presentation, and then we'll have questions after, which I'll support Rachel with as Anthony's not here. Thank you.
Thank you, Anne. Good morning, everybody. My technology skills are about to be tested here with sharing this PowerPoint. So please let me know if you can see this.
Yep, we can see that, Rachel. Thank you. All working.
Lovely. So I'm hoping the IT gods will be smiling on me today and this will run smoothly, but please let me know if there's any interruption as I go through this. So thank you so much for having me and good morning, everybody. So I'm going to present today about specialist and secured care delivery pathway, a little bit about what we do within secured settings, but particularly focusing on our Women's Health Hub at HMP Peterborough. So we provide services across a range of prisons. Previously, that had been very much focused in Bedfordshire and Cambridgeshire, but since July, we have started to move into the Nottinghamshire and Lincolnshire jails as well. So we transferred over HMP Loudon Grange on the 16th of July, HMP Ranby on the 1st of October, and HMP Nottingham just Wednesday of last week. And next year, we will be transferring into HMP Lincoln, HMP Moreton Hall, HMP North Sea Camp, and also Swinderby, which is a short-term holding facility. So we have expanded and certainly grown a lot, and are now the healthcare providers in all of these prisons, which, as you can see, has given us quite a geographical spread as well.
If you've muted by accident, Rachel, just as you switch slides.
Apologies. So in terms of that growth, we're providing the integrated healthcare in 8 prisons and an IRC, which was Yarlswood, and 1 offender personality disorder pathway. But this would expand by another 4 services by the end of next year. We are offering healthcare services to over 5,800 prisoners at any one time. And next year, by the end of next year, that's going to be 8,200 people. So we're reaching a lot of people in custody across those sites. We have at the moment around 300 staff working in our secured services, and we will have over 550 staff working in our secured services by the end of next year. So it's a big expansion for us and something that we're really excited about. So in terms of women's support in prisons, there are 12 prisons in England and Wales designed specifically for women. There are not a lot of women in jail compared to the amount of men in jail. So we have about 3,600 women in jail currently in the UK. 6 prisons have a mother and baby unit, having around 38 mothers and 36 babies. And HMP Peterborough, where we are the healthcare provider, is one of those. And we keep babies with mum up to 18 months. So it may be that a lady comes in with a very young baby and the baby can come with her and stay with her up to 18 months. It may be that a lady comes in and she's pregnant and she has a baby while she's in custody. And again, the baby can stay with mum up to 18 months. A quarter of these women are on remand and approximately 50% are sentenced. So actually, when we see a lot of these women in custody, they might be remanded. They might then not go on to serve a custodial sentence. There is a lot of focus around other options in terms of women's sentencing. And actually, we know that the outcomes for women can be a lot better, particularly where there's a young baby involved, where we can look at alternatives to custodial sentencing. So women in prison, as I say, a very, very small part of the people in custody in the UK, just 6% of our cohort are women. Peterborough is the only place where we have women prisoners that we look after. So women in prison are also known to have higher levels of health and social care needs than their male counterparts. There is a lot of complexity with our women in custody. Quite often our women in custody have been victims of crime more so than perpetrators of crime. And there's a lot of complexity that then comes with those women when they come into custody. 90% of women said that they'd access a nurse and 84% access a GP, 52% using the mental health services. So this is our women in custody at Peterborough, but across the female estate. So we can see there's a really high level of need for healthcare services for this cohort of ladies. So a little bit about Peterborough. Peterborough's been open since 2005. It's the only prison in the country that has both men and women. Of course, they are separate parts of the prison, but it does have men and ladies and also our mother and baby unit. The prison is also privately run, so it's not run by Her Majesty's Prison Service, it's run by Sodexo, and maternity input is provided by North West Anglia Foundation Trust. So you may hear that referred to as NWAFT, and our relationship with NWAFT is we look after mum, NWAFT look after baby, but of course that's very much a partnership approach. We've got 360 ladies in there at the moment. And we've got some increased focus recently in terms of how we look after our female offenders. So we have a dedicated women's health service, including gynecological services, introduction of enhanced support services for our ladies who need a little bit extra input, introduction of a women's hub, and we'll hear from Eleni, who's our women's hub lead, in a moment, who's done a very helpful and insightful video for us. And a dedicated women's hub lead, which is Eleni, that we will hear from. So a little bit about the hub, but Eleni's video will do it a lot more justice than I ever will. It's designed to address the fragmented care that women had been experiencing in secured services, and particularly within prisons. A lot of our female patients are survivors of sexual violence and domestic abuse. And as I mentioned earlier, most of our women are victims of crime much more so than they are perpetrators. So the idea of the Women's Hub is to bring together all of the different elements of healthcare and to have a really holistic approach in meeting the needs of the women in custody, recognising that those women are inherently complex, lots of trauma, lots of abuse and violence, very recent work being done to investigate brain injury. A lot of our women in custody have had repeated violence that's resulted in organic issues around brain injury. So we know that there's a lot of complexity around these women, and we're very much working to bring together a very one-stop shop approach to their healthcare, so that they're not having to approach multiple people, that we're taking into account the whole person, their history, the trauma, the mental, physical and substance use needs of that person, and treating that as one healthcare model. So we have a dedicated patient engagement lead at H&P Peterborough, and one of the things that we're very keen to do is develop our services with co-production. So our patients telling us what they need helps us design a service to meet those needs. So we have been asking our female patients about how important it is that they can see female clinicians. So we've ensured that there's a female GP available. We know that can be a real barrier for some of our women in custody if there's not a female GP available to see them. And we've also been exploring with them about creating the right space. So part of the Women's Hub is not just about having the right clinicians there and having female GPs available. It's also about creating a space that's calm and somewhere that the women are able to engage with us, and doesn't feel like a prison, but also doesn't feel too clinical as well. So health promotion, improving health literacy is also a huge priority for the hub. And again, we're very much working with the ladies to understand what it is that they want from their hub. And we got some fantastic feedback telling us about areas of health that they feel that they would need support with, or they would like to know a little bit more about, or would like a little bit more education about. So there's a little bit of a breakdown there. I think it's incredibly interesting that you can see that huge chunk, 27%, that relates to trauma and mental health. So we know that these ladies are recognising their own health needs and communicating with us about what it is that we need to be delivering to support them. So in terms of development for our Women's Hub, in April 2024, we started our dedicated Women's Hub and our dedicated gynecological clinics. In April, then we also introduced our enhanced support service. That service is a psychologist, a nurse, and administrative support. And we also have some dedicated officers as well. So we have officers who work on the women's side within Peterborough. They really can then get to know the women and build those relationships, which I think is really important. We then, April 2025, had the Women's Health Hub commissioned, and May 2025 dedicated funding to have a women's space. So that's more trauma-informed, less clinical, less custodial space for the women to be able to come and engage with us. So it's, I think, a really, really positive sign in terms of the investment and the commitment for improving women's health in custodial settings. As I've mentioned about co-production, our patient voice is the most important thing to us, really. So we have a good idea about what services we need to deliver and how that should look, and we work with our NHS England colleagues to do that. But having our patient in the centre of those conversations is absolutely vital to making sure that we are delivering what needs to be delivered and what the patients really need from us. So initial consultation with patients has really helped us with a gap analysis. So areas that we might be ill-informed on, we might not have that insight to, has really helped us to identify some areas which are noted here for things that we need to improve, include, and do better on. So I mentioned Eleni. So Eleni is our Women's Hub lead. Eleni has done a very helpful and insightful 5-minute video. So if IT is working, I am hoping I'm going to press play and be able to share that with you.
Hello everyone, my name is Eleni and I am the Women's Health and Wellbeing Hub Coordinator for Peterborough Prison. Thank you for giving me the chance to share a little about our work and the impact that the Hub is already having on the women in this prison. So the Women's Health and Wellbeing Hub is a new model of care designed specifically for women in prison and for anyone with a cervix who may need women's health support. The Hub sits between primary and secondary care, and what that means that we can offer more advanced support than a GP alone, but without needing hospital referrals unless it's absolutely necessary. The main aims of the Hub are to improve access to essential women's health services, act earlier, prevent illness and reduce health inequalities, to provide care close to the patient in a safe and a less traumatic environment, join up multiple needs in one appointment if possible, improve access to information and self-management tools, and offer a better, more compassionate experience, especially for women who came from prison with significant trauma, excessive history of abuse or substance use, and significant mental health needs. So my role as a Hub coordinator is to support high-quality trauma-informed women's healthcare, while my clinical expertise is sexual and reproductive health. This role includes designing and strengthening women's health pathways, coordinating joined-up care across multiple services, ensuring strong governance and safe clinical practice, leading and developing the sexual health team, and working closely with primary care, midwifery, mental health, domestic violence support agencies, and community services. It also involves creating self-referral options, clear local pathways, and easy to understand health information for staff and our patients, and making sure women receive the right care at the right time in a safe, respectful, and in a person-centered way. So I would like to share an example that shows why this Hub is so important. So a 31-year-old woman came into custody pregnant, heavily intoxicated, withdrawing from severe substances, and with a long history of trauma, domestic abuse, and self-harm, and significant mental health difficulties. She was frightened. She was very unwell physically and didn't know how far along in her pregnancy she was. So within the first couple of days of her arrival, she was seen by our GP, our advanced clinical practitioner, the midwife, and the perinatal mental health team, as well as the recovery services and the sexual health team. We arranged an urgent antenatal screen, which confirmed that she was already 22 weeks pregnant. She started a safe detox and stabilized her withdrawal. She had a sexual health screening, which identified incomplete syphilis treatment and arranged an urgent therapy with community services. And every service connected straight away through daily safety huddles and weekly MDT, so we can have follow-ups, regular discussions about the case and connect with the right teams. So over the following days and weeks, the patient received trauma-informed emotional support from all the relevant teams. She engaged with well-being sessions and mental health services. She had regular antenatal checks and monitoring, and she slowly began to trust the process and the people that they were caring for her. And just after a month of her in the healthcare, she was progressing very well with her detox. She was stable and fully engaging with all disciplines. She was planning for her release with the midwife, the recovery, and the community services. And the patient eventually said that she felt finally safe, listened to, and very supported. And that has an impact on her overall well-being and how she would then she was aiming to look after herself and the baby in future after she was at the prison back in the community. So her journey shows how critical timely access to joined up compassionate care can be, especially for women in crisis. So while we're still at an early stage with this model, we're already seeing the impact that this model can have and how much of a difference it can make to our women's life. And so with continued partnership and support, we can keep building on this work. So our next steps includes developing a dedicated trauma-informed space for one-to-one as well as group sessions. It involves on-site support from specialist agencies for domestic abuse and sexual assaults. It involves an in-house LACS service to improve access to contraception. LACS is long-acting reversible contraception. We are planning to strengthen our links with community services for continuity of care and a full program of educational sessions on sexual and reproductive health. And these developments will help us to create a service that truly improves outcomes, reduces inequalities, and provides women with a safer and more coordinated and more compassionate healthcare experience. Thank you.
So I don't think I'll be able to do justice to the work in the same way Eleni can, but hopefully I can summarise some of those points that Eleni has spoken to. So some of our quality improvement work, we are looking to do further work around supporting the women in custody at Peterborough around menopause, contraception and sexual health with an integrated mental health referral approach. We need additional DV support, and as Eleni mentioned, we're looking at dedicated space that the women can feel safe and able to trust and engage with us. Further staff training is underway in terms of cervical screening. Quite often when the ladies come into custody, they have neglected their health needs for prolonged periods of time. So they haven't been going for cervical screening, they haven't been going for routine important women's healthcare. So we are working to engage the staff and the women around engaging with some of those important health checkpoints for those people. The focus is always to be patient-centred, make sure that our patients can engage with our services and that we have services that can meet the needs of that cohort. Working with our community colleagues, so ensuring that there is continuity of care for those women when they then leave custody to continue engaging with their own health and giving them that autonomy to be able to work with GPs, attend appointments, things that might not have been manageable or possible for them prior to being in custody. Continuing to work on our patient experience and co-production, and also producing educational resources in multilingual formats, easy to read formats, and we're very, very cognizant of our neurodiverse population within custody. We know that we have a lot of neurodiverse people within our custodial settings, so ensuring that while we're communicating with posters and leaflets and materials, that we're doing it in a way that there is a version that everybody can access. Next steps I've discussed, but a lot of focus on upskilling our staff, making sure that our pathways are robust and also clear and easy to navigate for the women. We know that people in custody will not engage with health services if it's complicated and if you have to engage with lots of different people. So we want a really, really smooth, easy to navigate pathway for our patients within our custodial settings. As I mentioned, working with our community colleagues, monitoring and evaluating what we do. So establishing our key performance indicators, but then also doing some really meaningful data collection. So we've got the performance and KPI element, but we've also got some of the stories and some of the narrative from our patients as well to help understand that we are going in the right direction or not, and what we need to change and adapt as we progress. And then continuing to work with our commissioning colleagues, as the timeline demonstrated, to identify that there's additional resource or additional services needed that we can work with NHS England to fund and provide. Thank you so much. And yes, if anyone has any questions, then please feel free. Thank you.
Thank you, Rachel. That was a really excellent presentation. And I think having a worthwhile wait for Elaine's video to come on for us just helped to really bring to life in a three-dimensional way the tremendous work that's taking place. As I said earlier, it really feels like incredibly innovative work, but very holistic work to really help address some of the inequalities this cohort faces. So a number of colleagues have now got their hands up, so let's bring in. I'll start with Joe.
Thank you, Faisal. Rachel, thank you so much for a really comprehensive report, and please extend our thanks to Elaine and the rest of the team for that brilliant video. I've had the benefit of visiting the Women's Unit at HMP Peterborough, and it's just such an oasis of calm, so I can't reinforce enough some of the statements that you made about the context within which you work. I could go on for a long time, but I've got two questions, one of which is more of a statement, so I'll do that one first, which is, you touched upon it in your introductory slides when you were talking about the numbers of people involved, but I do think we need to recognise the difference and the difficulties that arise through fundamentally two different groups of patients within the system. The first is those on remand, who are a very different population in terms of the length of time that your team have to work with them, and those who are more of the settled prison population. And we shouldn't underestimate the complexity that that brings to the care pathways. But my question, and it latches onto some of the case study that Elaine talked about, but it also picks up on your next step slides, is that element about health literacy and self-care. Because obviously every point of contact with the women in Peterborough, let's use that as the example, offers the opportunity to prevent future issues arising, because when your team meet people in that environment, they're not only dealing with their current presentations, but there's obviously a lot of baggage that comes from the past that's brought them to that place in their life. And I just ask about that next steps of community collaboration. And are there any barriers for your team? Because obviously the ongoing care of those women ensures that their future is very different to their past, and whether that involves, for example, housing providers and other parts of the community. So yeah, are there any barriers in that arena?
Thank you. Yes, absolutely. I'll just in terms of the remand and sentence population, very, very different. And we have very different roles in those people's lives, depending on where they are in the criminal justice system. I think one of the continued barriers for all of our patients in custody, but particularly our women, is around safe spaces when they leave custody. So we're able, as you described, to create that oasis within Peterborough, within our mother and baby unit. And I think one of the barriers continues to be having then a place that the women can go that is safe and allows them a little bit of a fresh start, because quite often for the women, being able to continue the work that they've done in custody around their health literacy, around safety, is being able to move them into a space where they're around different people and a new environment when they go back into the community. We're very, very lucky that we have our MWAF colleagues who provide support for the babies in the mother and baby unit. We've got fantastic relationships with our GP colleagues. We're also very fortunate that a lot of our senior clinicians within the organisation work within and have very well established relationships with our community pathways. So I think we can offer a lot in terms of the health pathways, but I think certainly in terms of safe space for women when they leave custody, to be able to come into a new environment around new people can be a real challenge for them.
Okay, thank you. That's really helpful. Thanks.
Tim.
Rachel, thank you. That was outstanding. Really, really good. You should be really proud of it. My question links to what Joe was talking about, just with my primary care hat on. And you talk about links to the community and what happens next for people, because they go through this amazing service. It's life-changing, and then they get put back out into community with GPs. And love the service that GPs provide at best, but it's very nebulous. You know, you've got hundreds of GP surgeries providing a very different level of service. How do you make sure, what can you do to ensure it does as consistent as possible? Because I'm really conscious that some of these people will struggle to get the action they require. Others will fall into a great GP surgery that will offer them very personalised service and look after them. And it's just that differentiation between services that I'm really conscious of.
Thank you. Yeah, we work with a lot of GPs, and of course, because we have a very small women's population, there's a big geographical spread. So there's not a lot of prisons for the ladies to go to. So actually, our women in Peterborough aren't from Peterborough. They're from all over the country. So it is absolutely a challenge, because we're working with returning women back into the community, back to home areas, in areas that are all over, because there's not many places for the women to go in custody. We do have really well established, I think, relationships with GPs and community. It is a challenge, but I think that's where we have a really key role in the continuity of care piece when we're planning patients' discharge. So as soon as a patient comes into custody, we're thinking about what does discharge look like for them, what does release look like, and trying to build those processes and build those connections and book their appointments for them. We also do introductory work with the women in terms of services that they might engage with in the community. So we'll try and introduce them to those people before they leave, and also make sure that we do a really, really robust handover to the clinical services receiving them, so that they understand all of the history, all of the work that's been done, and the patient's objectives going forward. So it absolutely is a challenge, but I think one that we navigate by the moment the lady comes through the front door of Peterborough. We're thinking about, what does this look like when you leave?
Yeah, thank you. And did you want to come in on that point as well?
Yeah, I just thought it was important to share that holistic part of what happens in that safe space. So what's important in accessing care in that safe space is not about the ability to access different types of care, but also to look at the trauma part of things, to think about and to have the psychological intervention, because there will be cases where we cannot change what the outside world looks like, but what we're working to do is work with someone to look at what are the triggers, where are their strengths, what things would be important to have in place beforehand, what information would the GP maybe need, and how would they access, and almost like go through what they're putting into that access in the community, because it is such a broad range of services and situations that people are leaving from. It's that moment of calm to be able to do some of that psychological work that enables different choices, and feeling that actually giving people a sense of that they are important, and how do I speak up, and what things are trigger points that I need to really avoid when I go into the community. So I think we really have to balance both sides, and I know I've seen with team how well they do that, and in ways they don't even realise, by just modelling a different way. And that's the beauty of having this safe space in Peterborough.
Thanks, Dan. That's very helpful. Give it a bit more context in there. Julia.
Thanks, Faisal. I'll be really quick. Rachel, I'm Julia, one of the non-exec directors. Hi, and a health visitor by background. And I absolutely recognise the passion and commitment to getting a new pathway up and running. And I just wanted to say you've come across as absolutely, both yourself and Eleni, your compassionate approach to dealing with the ladies in your care is absolutely phenomenal. You're just fabulous role models. You know, you're working so hard to make life much easier and empowering people across the board. So huge thank you, I'm sure, from everybody, but just wanted to recognise the two of you and the rest of the team. But your commitment and your compassion just absolutely shines through. So thank you.
Yeah, thanks, Julia. I think we'd all endorse that, Rachel. So please convey that back to everybody in the team as well. Melanie.
Hi, Rachel. I'm also one of the non-executive directors with the trust, and I echo everything that everyone has already said, of course. But Rachel, I'm interested in particular around how you're sharing the model that we've developed, and indeed how you've reached out and how you work maybe with other women's prisons or women's prison services to bring in good practice from other sites. So can you just maybe share with us a little bit of how your network enables us to continue to innovate and continue to develop?
Yes, of course. Thank you. So one of the benefits of the women's prison estate being very small is it's quite a small network. So our head of healthcare in the women's side of HMP Peterborough is Rachel Patman, who's a nurse by background and has worked at that prison for a very long time. So Rachel is part of a network with other heads of healthcare within the women's estate. As mentioned in the presentation, we've got 6 prisons now that are serving women across the prison estate. So they're very, very much connected. Although we have a large male estate, the women's needs are very, very specific, and there is an existing network then of those heads of healthcare who also have very specific and quite unusual roles within custody, because our female estate is so small, just serving around 3,500 women at the moment, whereas I believe we're around 90,000 men. So it's it's a small but very experienced network.
Thank you.
Thanks, Rachel. And did you want to come in on that point as well?
Yeah, and David might say the same. There's also the benefit that there is a strong commissioning leadership in women's health in prisons, and the commissioner locally who commissions this service is leading on a national front as well. So us being able to link in and work with her and think about how partnerships and collaborations and collaboratives can work in this environment, which is traditionally been very it's a very traditional way of commissioning in prisons. It's about thinking about how do we do that differently, and I think women's health is one area which has got a lot of national ear to it about how we could maybe do that differently. So the fact that we are linked in to the commissioner for this area is really, really important as well. David, I think you might have more on that. But...
Yeah, thanks. David, if I bring you in.
Thank you. Thanks very much, Faisal. And I think that helping the women's estate understand direction and ways of going has also been influenced by Sunil Ladd, one of our psychologists. And he's been able to run, I think, Rachel, it's trauma-informed training, but I know he's met all of the governors of all of the women's prisons across the country to help them understand a different approach and a way of thinking. So that sharing of ideas, helping others learn, has been something, the examples that Rachel's got, Anne and the commissioning, and then also direct impact. So hopefully, Melanie, we're reaching out quite broad to share that model and that way forward.
That sounds really impressive. Thank you.
Yeah, thank you, Faisal. And thank you, Rachel. I'll add my words of congratulations and thanks for really informative briefing at this board meeting. My name is Duncan Orme. I'm a non-exec director and also chair of the Audit and Risk Committee, and previously worked at St Andrews Healthcare. And I draw that experience when I reflect on the risk to service users, patients, and those having served a custodial sentence as they cross the boundaries from one organisation to another for their care. So I'm minded to return to Tim's question, if I may. And as I listened to your answer to that, it struck me how many times you said this is a challenge. It also struck me the number of times that you said, we try to do this and we try to do that. And I wanted to give you the opportunity, if you could, to just reflect for us in the board on the role that we might have in educating the 6,000 plus general practices out there as we pick up the care for patients, male and female, to be perfectly honest. So to make sure that that transition is as smooth as possible. I see Anne's hand shooting up, so you may well be having some assistance with this question. Thank you. Thank you, Faisal.
Yeah, Anne, if you want to come in.
Yeah, I think it's a challenge, Duncan, is it, about how we get a change in the strategic way of working in primary care across the board. The teams do a fantastic job at influencing through how they connect and how they work with practitioners from a primary care, and that's absolutely important and can make all the difference for an individual prisoner and their release and what happens for their family. I think also there's something about how we influence nationally, and we've got colleagues in secured service who are in national forums, and Caroline Watson, our Deputy Medical Director for Specialists and Secured, is on a GP Royal College. I'm going to get the acronym not quite right, David, I'm sure, but basically secured GPs.
RCGP.
There we go. The secured GP network, which influences wider to primary care and how that policy needs to change and make a difference. We also have a number of GP practices that work particularly for those who struggle to access services. We have one in our own county, which is Maple Access Practice, but there's one in each locality, and it's looking at how that network also supports some of this work. We've also got Sunil, who's a national director for secured services and prisons, who's also influencing some of that policy change. So I think there's kind of a range of things that as an organisation we're doing. There's the individual pathways and connections, and then there's the influencing policy and influencing professional colleagues through GP practices.
Yeah, thanks, Anne. Duncan, did you want to come back in before I bring Linda in?
Yes, Faisal, if I may just reflect on what I've heard, I think our trust is doing amazing work. I think we've got some inspirational leaders in this field who are doing local, regional, national work. But I think the point I was trying to bring out, Anne, was what I heard in the presentation and the answer to the questions, and to encourage the reflection of what more,
yes,
if possible.
Yeah.
So it was no more than that. But Anne, Rachel, I think that's amazing work, and you know, given where we are on this journey, I think it's an amazing achievement. So please don't take it as a criticism. It's just really actively listening to what our colleagues are saying to us. Thank you, Faisal.
Yeah, thanks, Duncan. And then if I finally bring in Linda, then we'll move on. Thank you very much, Linda.
Thank you very much, Chair. Just to mention a huge thanks to Rachel and other colleagues who have not been able to come in to do the presentation, and Delaney. HMP Peterborough is one of the prisons that I visit very regularly, and as a former prison nurse, I'm always happy to go into the prisons. I did want to sort of share further information with regards to the queries that have been raised. So I'll talk to the first one that Joe raised around how we can then, sort of support the women as they are leaving prison, and actually what are those barriers. So one of the things we do really well, Joe, is our multi-agency working and our planning. So Rachel did allude to that, but actually when we work in a multi-agency framework, it then means that we are coming together to ensure that that follow-on is actually picked up. So things like our probation services then come in, as well as other professionals. So for those moms who actually have babies, there's a reliance on areas like our social care colleagues. So they may be under a plan because it's a child who's identified as potential risk. So that safeguarding input then kicks in, and that's the frame and structure that's then used to support. So there'll be various things that we then utilize, but social care do have a role in that. And then just coming into the point that Tim raised around the difference with the services, I just wanted to add in that one of the things we need to always sort of be mindful of, certainly for us in NHFT, is that there will be women coming out of prison who want a new start. So how you plan, refer into other areas, we could be very limited with regards to that, because it's not unusual that actually someone has been involved in something and they did get arrested, but it could be related to gangs and other things. So they then move to another area because they now need to assume that new identity. So again, the work we do with them, using that holistic approach to empower them, means they're able to then they're then able to be signposted to other areas, and they can then access that information, because even we could be limited with regards to that. So it's not always straightforward that we can then send your information here, because we do have those situations where people are looking to have that new start, and absolutely they require that protection. But we will always work with other agencies to ensure that continuity of care wherever the individuals are going. I just wanted to also come in on the points that Melanie raised with regards to how we share this more broadly. So Dr. Caroline Watson is our acting deputy medical director in forensics, so with the turnaround prisons. She's got a national role and a national profile. So she's the chair of the Royal College of General Practitioners Secure Environments Group. So that feeds into general practice. And actually that's really instrumental, because it's shaping how the work is then followed through in the community with general practice, recognizing that a prison setting is a prison setting is a community in itself. So how do you expand that further outside of the prison? So that's always useful, having Caroline lead on that work. And actually, it's one of the things that we're really proud of in NHFT, because again, it's showing the good work that secure services are doing. There's also a group that Liz Walsh, who is the UK professional lead for justice and forensic nursing with the RCN, has set up for colleagues who are heads of nursing. So Tracy Healy, who's one of the heads of nursing across the Cambridgeshire prisons, I linked her with Liz Walsh, so she's in that group. It provides them their individual support, but they've got a community of practice in that. So again, we're able to share the work we are doing, and that is outreaching, because it's not just to NHS, it includes the private providers providing healthcare into prisons. So we outreach into all these areas and are certainly shaping and influencing. The other things that we have done, which I think colleagues will be aware, we've had quite a number of visits from NHS England colleagues. The prison is usually inundated by other areas wanting to come in and learn, which obviously you have to manage. So that is another way that we're actually outreaching. The one thing I wanted to then highlight to board is, when it comes to the women that we are supporting, the key thing is the outcomes. So whilst they are in the prison and they are leaving the prison, you will find a lot of them then come back and say, actually, I now want to pursue hairdressing. I now want to pursue this. And that's the hard work and good work of our team. They absolutely work with women to actually support them to have a more positive outlook in life, because a lot of people being arrested in itself will be a knock on your confidence. Will I ever get a job? Will I do? They do all that work. And because they do it, it's not something that they'll be shouting about on a day-to-day basis. But the outcomes of those women, and certainly those with babies, is really, really positive. And we've seen people being reintegrated into their communities and actually start to carve a new pathway, which then leads to them being someone who is contributing into their communities and able to raise their families. Thank you.
Yeah, thank you, Linda. I mean, that was incredibly informative and helpful. I mean, the key takeaways, Rachel and colleagues today, was really very much about the health inequalities, the outcomes, the kind, compassionate care that we're really focused on for this cohort, and that trauma-informed kind of planning and psychological support. Incredible piece of work that's going on. Just remind me, Anne, I believe that expansion of the secured and specialist services is something that we were asked by NHS England to take on, and because of our good track record and some of the great work that's taking place, I'm seeing you nodding, so yeah. I've got that right. So please forgive me, given that I'm still getting to grips with all of NHFT's work, etc. So no, Rachel, absolutely excellent presentation. Thank you very much for your time and sharing that with us. You could tell from the number of comments and questions, both in the chat and also live from colleagues, how much it's been valued. And I think as Linda said, we're really very much focused on achieving the very best outcomes. And if we can help support this cohort to get a better outcome outside of prison once they've been released and not on remand, and the better outcomes, it's always the best thing that we can do for them. So thank you very much for all of the work and all the innovation that's taking place in the Women's Hub, and long may this continue, and more that we can replicate in other places as well. So thank you to you and all the team.
Thank you, Faisal. Thank you, everyone, for having me. Thank you for being so patient with my terrible IT skills. And yeah, it's been a pleasure sharing that work with you. And I'm 20 years into working in prisons, but a year with NHFT, and it's really exciting to me, with such an extensive prison background, to see the prison work held in such high esteem and given the attention and focus that NHFT choose to give to that work, because I'm sure Linda, who I know has worked in prisons for many years as well, will remember the days where this was just stuff that happened behind a wall and we all pretended it didn't happen, and we didn't give it the due attention. So thank you, everybody.
Thank you, Rachel. No, absolutely.
Thanks.
Right. Thank you very much to everybody. And I always feel the presentations and the always set the board meetings up for a really good session. So already we're into a very good session, and also behind time. But then I was expecting that with a presentation like this. It's either that or a really bad chair. I shall leave that for you to decide as we move through the agenda. So we move into our risk section now, and this is paper D in your pack, which is our risk report. And Richard, I believe this is with you.
Thank you, Faisal. Yes, indeed. Good morning, everybody. So the paper in the pack presents, as usual, to the board the latest position reached in the management of risks to the delivery of our strategy via our BAF. I'll just draw out 5 points from the report, which I'm sure everybody's had the chance to have a look through. So overall, we continue to operate at a high to significant risk profile, but nevertheless making good progress on a number of areas, as summarised in the table and shown in more detail in Appendix 1. As we've been discussing over the last few meetings, we've been doing quite a bit of work on operational risks and linking those to the BAF. What we've done this time is to separate out all of those operational risks into a single table. Hopefully this makes it easier to see and peruse them. They're also in the pack at page 41, at least in my version. We've included for reference a copy of the risks that we're managing in common with LPT, which we're terming our group BAF. Although not the subject of detailed discussion today, they are here for your information as they form part of our risk profile as NHFT. We'll have the opportunity to discuss these as a board in common with LPT board members at the next group board meeting, which is taking place in January. So as mentioned by Faisal earlier, in welcoming Sarah as our Group Chief People Officer, we're moving towards now an aligned approach to the people agenda across the group, since work has already started in that vein on culture and staff experience. You'll see within the report that we're proposing to move the corresponding risk, so this is BAF 005 on the trust BAF, into the group arena to be managed in common with LPT. So we're seeking the board's endorsement of that proposal from the SEB. And then finally, just wanted to highlight in the report the reference to the work that the ICBs have been doing since they've clustered. They are reviewing the risk profiles for LLR and Northants in the new LNR configuration. We're obviously staying close to that. And as that work concludes, we'll obviously bring more information into the board and committee arena for discussion. With that, Faisal, I think I'll hand back to you for any questions or comments on the report. Thank you.
Yeah, thank you, Richard. Very good highlights from the paper. And as I say, with all the papers, I always assume the papers have been read and just ask the report authors just to pick out the key highlights they want to draw the attention to board members. Duncan.
Yeah, just a couple of comments, if I may, Faisal, rather than actual questions. The first is to note that executive colleagues working with Richard have been doing much work, I think, to strengthen the linkage of the BAF to the operational risks. Not all of that has yet flowed through into this documentation, but I wanted to take the opportunity to bring the board's attention to that from the work we've been doing at Audit and Risk Committee, and to encourage continuation of that. It is a feature that we're wanting to see across all the Tier 1 committees, so we can see that line of sight of operational risks through the BAF. My second point was really just an observation for conversations and discussions later, and that is that, you know, in particular, a number of these risks have been relatively stagnant at their level of risk score. And I think there are few opportunities through the year to actually see some significant movements in those. And during the planning round is one of those opportunities to listen out to how we're working with our partners across the health system to see some of these risks move in hopefully a southward direction. Forgive the nature of that. They're 2 points rather than questions, Faisal.
Yeah, thanks, Duncan. And we've included the operational risks that are aligned to the board assurance framework in the pack as well for the work that's already been done thus far, as you allude to, Duncan. So thank you for that. Joe.
Likewise, mine are comments rather than questions, and I sort of echo Duncan's first point, but elaborate on it on a bit more. We've still got quite a lot of gaps in the documentation, particularly there's some of the BAF risks stand out noticeably for particularly the control gaps and the assurance gaps. And I, you know, this has been an ongoing situation now for a number of cycles, and I really think that, you know, if we're relying upon this for assurance purposes at board, we have to see these documents completed with a degree of consistency and detail, which currently isn't there. And the other one is, and I don't know, this may be my complete ignorance, the fact that the scoring has stayed, I'll use a slightly different phrase, static over recent cycles. It may be useful for the board to have some commentary in the covering report, Richard, about where any debates have taken place over reevaluating the scores, just to highlight where there have been debates, so that we're confident that those risk scores and target scores are being stress tested on a routine basis. That was all from me. Thank you.
Yeah, thanks, Joe. I think, Richard, if I bring you in first, then I'll respond as well. Richard?
Thanks, Faisal. Yeah, just on the point about gaps, Joe, I guess just clarifying really that where we're seeing a blank column, I guess, so to speak, for control gaps and assurance gaps, that reflects that there aren't any gaps that we're aware of in controls or assurances, so is in fact a positive position. However, of course, if there are gaps in the actual control column and the assurance columns, then absolutely we need to be hunting those down. So if there are some particular ones that you're concerned about, do drop me a line because we'll pick those up in the next review with execs.
I think in that case, if there are no, so example BAF 002, there are no actions, there are no progress commentary in there. If there are none to report, I think we should have an acknowledgement none, and then we'll know at least that somebody is paying attention to it. And also on that BAF, the second line source of assurance on effects remains blank, and it has been for some time now. And those are other examples, but I'll drop you a bit more detail, Richard.
Thanks, Chair.
Yeah, thanks, Chair, and thanks, Richard. And also, just to support the discussion that we've had a number of board development sessions on the board assurance framework, where we do go into much more detail and a deep dive on the board assurance framework and the risk and how these are aligned. And I think it's a real opportunity for board members, if you have issues and concerns about anything like that, like Joe, you're raising some gaps, etc. I would always urge board members to pick this up with Richard and the team outside of a board meeting, so not just to wait till we get to board to have that conversation. I think it's really helpful, and then make sure that we're fully assured when we come together collectively as a board. That would be very helpful. So Richard, I think you've got, Joe's going to drop you a line on a few points, and then we'll pick those up. Anything else on risk at this stage from anybody? No? Okay, well, thank you very much. Before we move to the decision, one of the things that came up in our joint board workshop with LPT a couple of weeks when we were talking about the board assurance framework, when it came up in conversation, is that there are some group board assurance risks that are being looked at a group stage together with LPT. Regardless of it being a group board assurance risk, the discussions can happen at both organisations independently. They don't have to wait for group discussions. And actually, I would be minded to remind all board colleagues that in your level 1 committees, you can be looking at those individual risks, irrespective of the group looking at them. That is just an opportunity for the group to come together, the group responsibility to consider that as a group, and it might be assigned to the group, but that does not remove our individual independent organisations looking at those. So please feel free to pick those up in level 1 committees, and if there are issues or things that you want to pick up, we can take those discussions then when we do come together as a group. So I hope that's also helpful, because I know I've had a couple of conversations with colleagues individually, both in LPT and NHFT, but I just felt it was important that we made it clear that just because it is assigned to the group doesn't mean those conversations only happen at the group level. They can happen individually as well in level 1 committees in our separate organisations. So having said that, then we're being asked to receive the board assurance framework of information on system risk and endorse the recommendation. The board assurance framework 005 is overseen in the group meetings and identify any areas for which requires further assurance. Colleagues all happy to receive that, endorse that? No? Okay, thank you very much. And we're then moving on to a verbal update with you, Anne, which is a system-wide winter planning and risks.
Okay, thank you, Faisal. And we are really in the heart of things at the moment with winter approaching, and as you'll have seen in the press, there's obviously flu has hit in many places slightly earlier than predicted. What I can say is that we have been progressing with our system winter plans, and each of the schemes is on track and working well. And then that's across the board in UHN, in NHFT, in our local authorities, supported by the board run by the ICB. What we're seeing is that we're being able to hold our position really better than we have been able to previously. And in the last few weeks, as a number of the schemes, particularly the ambulance handover bay at NGH, has come online, we're able to be in a de-escalated position in the sense of pressure on our front door services, and that's been a real tribute to all the staff working in those areas. And I think that the feedback we've had from NHS England has been positive. No way are we out of the woods. This is still going to be a tough winter, but what we're seeing is the plans we have put in place have made a difference in our position heading into this winter, and that has given a level of confidence not only to us as leads, but particularly to staff on the front line who can feel a difference in day to day. NHFT have played a really important part in that, in their urgent care work in the community to avoid admissions, but also in the increase of community beds at Spinneyfields. So we're really seeing a change there, and I'd like to also credit some to our voluntary sector who have also supported many of the schemes that are happening. We've also had GIRFT for mental health at both NGH and KGH, and the Deputy Coup was pleased to announce yesterday in the Urgent Care Board how actually we had a lot of positives come through for our pathways in the community and mental health in this county, and I think that's a really positive and good feedback for our teams. Doesn't take away the challenge of how mental health and physical health all interconnects in that urgent care flow, but that nationally there has been a real increase in presentations, and we're really working together well as a system to try and manage that locally. So I'd say we are on track with what we're doing. We are holding our own as a system, and just really focused on getting the new pathways embedded well, so we can go into the Christmas period in a stronger position as possible.
Thank you, and that's really helpful to have a good picture, because I know in national briefings there's been a lot of pressure already being put on systems because of the flu uptick and respiratory issues, as well as COVID again. We're seeing bed occupancy really kind of taking pressure in particularly the West Midlands. I think we're slightly better in the East Midlands from my national briefing the other day. So thank you for that. Any questions for Anne or any comments before we move on? No, not seeing anything. So thank you, Anne. And then we move into our strategy section now. And the first part of the strategy section is environmental analysis. And this is with Deputy Chief Executive and Managing Director. David, that's with you.
Thanks, Faisal. So I think, Faisal, considering that we've got a number of agenda items further down, Chief Executive Report, etc., where I can pick up quite a bit of environmental detail, I might ask David Williams just to comment on the Advanced Foundation Trust application, because we're in the middle of that process now. But maybe if I cover just the Health and Wellbeing Board update. We've got probably 3 items coming through into next week for those boards. One on BCF, the Better Care Fund, which of course is important for us as we head into the planning round for next year. The SEND improvement plans are coming back through the Health and Wellbeing Boards, and again that's important to us because we know our 0-19 services continue to experience challenges post-COVID, etc., and ongoing kind of improvement work in that space. So we would play a role in that. And then just to update on the ICB exec structures, and previously they will come through to the Health and Wellbeing Boards next week. Most of that senior team, in fact all of that senior team, is now in place. And at the previous Health and Wellbeing Boards, Toby Saunders, who's the cluster ICB chief executive, had updated on the emerging strategic context for ICBs more generally in relation to their commissioning role. So again, all of that forms part of the context that we head into the planning round and the NHS long-term 10-year plan, of which the Advanced Foundation Trusts are one part. So on that, we're in the process of gathering our application materials, and I'll ask David just to make a few comments on progress, timescales, and then the implications for us as we head into Q4. Thanks, David.
Lovely, thank you, Dave. So the Advanced Foundation Trust status and opportunity, developing it at the moment for 8 trusts across the country as sort of early adopters, early aspirant trusts. So for benefits of the public, NHFT is one of those 8 trusts. The goal behind Advanced Foundation Trust status is successful trusts who have demonstrated the leadership, the oversight, and the way that fulfills the criteria will get greater strategic and operational autonomy, a regulatory approach that would be grounded in capability so that organisations would be given the space and the time to address performance issues as they arise themselves and find ways through, and also greater financial flexibility. So there's an opportunity that we're exploring going around that. And then that will also take us into the exploration that we're doing around an integrated healthcare organisation contract. So a contract focused around how could you commission services based on population need rather than on the functional services that most of the NHS is commissioned on at the moment. So that's all being explored through. And for the benefits of everybody, we received on Monday the initial data request from NHS England. So we are now processing through that initial data request, and the deadline for that submission is Monday of next week. When we meet together for the board development session on Thursday, we'll be spending some time looking at this process and the ways of working through. And the key thing that we're preparing for next is that the narrative, the description of what makes us NHFT and what makes us the Advanced Foundation Trust status would be due to NHS England on January the 5th. So the board development session next week and the work that we can then do, developing the stakeholders, our communications plans, our ways of working, gives us time to take all of that through to January the 5th. And then after January the 5th, when that submission's gone in, there'll be a process of assessment, which is including things like board observations, committee observations, and a board-to-board, with an expectation that we will know the outcome during April 2026.
Yeah, thank you, David, and thanks for the environmental analysis, Dave. David, I mean, I gathered the timelines are incredibly tight for this whole process. So there's a lot of work that needs to go on behind the scenes, including gathering all that information. So I don't belie how much work that's going to need to be done. I think we've already agreed that we'll be doing some of that work, as you alluded to in the board workshop next week. So we'll look forward to that. So any questions or comments for Dave or David before we move on? No, that's really helpful. So thank you very much. So we move on to paper E, which is in your packs. Again, I'll assume the paper's been read. It's the chair's report to the board of directors. Just a couple of things I'd like to highlight. I mean, obviously, we said goodbye to Christian at the last board meeting. She's done a wonderful job working with NHFT and also LPT as the group chair for the last few years. Left the place in a very good place for me to enter into as the interim group chair. I'm really looking forward to working with everybody. I've been in a number of induction meetings and introductory meetings with colleagues in NHFT and also system-wide and nationally, and they'll continue to the end of this year, and then hopefully we'll continue the working in collaboration and partnership. The Council of Governors workshop that took place in early October focused on the Care Quality Commission's well-led inspection. The workshop was really well attended, and it really focused the governors' support and understanding well-led and what their roles was going to be. And also in the staff governors changes over, we've had Lisa, who's now joined the Council of Governors, and she was in an induction program which I joined just to understand some more workings of governors and their roles, particularly staff governors. And just in terms of a very quick heads up on succession planning, we're very proactive on this area for our business. Joe, who's been appointed a non-executive director from associate from the 1st of January. Melanie, who's currently a non-executive director, will be an associate non-executive director from the 1st of January and Robin very kindly, who was going to be leaving at the end of the year, but has very kindly, whilst I'm coming into my role as the interim group chair, has very kindly agreed to stay till the end of March. So very much appreciated. And a huge thanks to Melanie, who's been the senior independent director at NHFT for a good few years, who's handed the reins over to Judith, who have been working very closely together for the handover. So huge amount of work gone on, and thank you for that. And just very finally, we had a very good presentation session at the joint group board workshop a couple of weeks ago, where we had Wakeman's, who provided a very comprehensive training session on Mental Health Act and some of the changes that are coming on through that, and the Mental Health Act bill that's going through its various readings in Parliament. One of the takeaways from that session was that it was so comprehensive. There was a few areas that we had to rush through because of time, and I think the view generally, talking to Richard and Kate, was that it'd be a great idea to bring them back in the future once the bill has reached through its royal assent in Parliament, and actually we might want to spend a bit longer on this area because it was incredibly informative. With that, you've got the report, invited to consider the contents and highlight any areas you want to discuss or any clarifications from anybody. No? Okay, great, thank you very much. And then we're with paper F, still in our strategy section, which is the Chief Executive's report, and this is with you, Dave.
Thanks, Faisal. So inspired by our Security Services colleagues, I'm using the theme of population health to guide some of the kind of input I make to the board today. So just segueing off from David's Advanced Foundation Trust update from the environmental section earlier, and of course taking the report as read, so I'm not going to go through in detail, but the population health theme is really quite important and exciting for us in the context of that application, illustrated by the Security Services bit, where we're supporting people both during a period of intervention with us, but also preparing them for a life and a second chance afterwards. So that's really important, and I'll talk a little bit about that at the end as well with one of our patients in Daintree. The medium-term planning framework has been published. It sets out the 5-year planning expectation for boards. We're having a discussion about it in, I'll give a verbal update later in terms of timescales, but we're also got some time in private to review, and then we'll have an opportunity then as we move into January and February to, in public board, begin to review the contents and the emerging detail in terms of that planning framework. We're of course working with system partners to develop our 5-year plans aligned with the 10-year plan, in addition to the 10-year workforce plan, where we've now been asked to supply evidence to shape the plan underpinning the health reform, with a particular focus on digital innovation and proactive population health. So again, linking back that thematic of Advanced Foundation Trust opportunities, population health management, and the workforce planning and the 10-year planning framework, focusing on those opportunities, which are, as I say, very exciting for us. We've also submitted our provider capability assessment. We're awaiting, that's our self-assessment against that. We're awaiting feedback. I've detailed that in the report. And that will, of course, feed into the NHS oversight framework, for which we're expecting Q2 results, probably next month. We would expect to see those, and also expecting a general kind of settling down of that assessment framework over the next kind of few quarters. So there may well be movement in scores. We would expect to see that as the framework matures and it beds into the system more generally. So by Q4, I'd hope that we're in a clear position in going into next year. Just in terms of local developments then, our quality awards were fantastic, which we had recently 16 winners, 47 nominees, and equally we've moved to expand 10 new community hospital beds for extended stay rehabilitation at Spinneyfields Care Centre. There's also a good example, again linking to our population health theme, of the text messaging services within our crisis line, winning a special recognition award. We've managed to get that up and running ahead of a national deadline of April 2026. And our school nursing service marks 10 years of text-based mental health support as well, which is an exciting milestone for our school nursing services. Again, really critical to population health management and making a contribution to the curve of people's life outcomes. We've updated on secured services. Ranby joined in October, Nottingham November, and following the earlier onboarding of Loudon Grange. We also had our AHP conference celebrating over 100 allied health professionals, which was brilliant to see. And also I thought fantastic that we were able to include colleagues from across the wider health system. So we had colleagues from St Andrews, etc., as part of that, which demonstrates our kind of leadership role in convening people for population health excellence. And then just linking back to that theme of population health, Lewis Sander, who's one of our patients, and he is happy for us to speak about this, has celebrated a 35-year milestone as the longest serving heart transplant patient in Northamptonshire, which I have to say bookending the secured services presentation with that update gives me such sense of pride to work in the NHS that we're able to, despite challenges, see really immense improvements in outcomes for people, and a tribute to Lewis and indeed to the team at Daintree for the support they've offered to him as he continues his life course. Thanks, Faisal.
Thanks, Dave. Yes, I would absolutely endorse those things. It makes you really proud to be part of the NHS when you have those stories. And as you say, the presentation we had, it's all about the compassionate care that's provided and the results of the care that's provided, that people are living with these transplants for so long. And what a milestone as well. Just before I bring in Julia, the other thing, Dave, was you alluded to it, which was the Quality Awards, and I had the huge privilege of attending the Quality Awards. It's absolutely amazing, the event that was put on, by the hard work that goes on, the unseen work by our communications team to put on such a wonderful evening to recognise our staff and our staff teams who go above and beyond, what you call the everyday work. And I think that recognition is so much needed to recognise those colleagues. And also I really felt that not just the winners, but all the categories and all the nominees really deserve to be there. And a huge thanks to all our sponsors who support that event, because without them we couldn't hold those events. And also it makes it cost neutral to the NHS because of those sponsorships. So a really enjoyable evening, with the nicer part of my role, I think, is a thing to say. Dave, did you want to come back in before I bring in Julia?
Remiss of me to omit the fact that we also had Doctors Awards, our resident Doctors Awards, which I suspect Julia may well be coming in on, but I'll let Julia comment on that, which was also a fabulous, warm, loving, kind, lovely evening. Just gorgeous.
Yeah, thanks, Dave. Julia.
He's taken all my words. Yeah, no, thanks, Faisal. I was just going to reiterate the Quality Awards because it was stunning, and just the appreciation in the room from the staff, I think, for each other. And it was a great networking event, not least the recognition of everybody too. But the Doctors Awards the following week, which a few of us were at, was incredible too. And it recognised doctors and dentists and some of our trainees as well. And I think it's the first one we've held as an organisation. And again, much appreciation in the room, and just a fantastic opportunity to network and to thank everybody for their hard work, for a group of people that don't always get recognition externally, from us. So I think, all Dave's words. It was a lovely evening. So thanks for the opportunity just to share that.
Yeah, thanks, Julia. I think we'd all support and endorse those, because I think, as you rightly say, sometimes it can be understated that, or even overstated at times, that these events are, just an opportunity to just go and have a bit of a what the people say, what's the colloquial term, a knees up, actually they're not that at all. They're actually a real opportunity to bring people together, share some really good practice where people are going above and beyond and really sharing that learning, and actually then recognize those people who do go above and beyond, which I think is incredibly important. It's one of those things that I firmly believe in, and I think you know it's the energy that people then take away from those events and back into the organization with their colleagues. It has a ripple effect is the way that I would describe it. Joe, final point from you.
Yes, thank you very much. Dave, just a point of clarification on your trot through the Advanced Foundation Trust status thing. In the report, it alludes to the new model supporting the shift to community-based models of care. Just so that I'm clear, is this sort of the new ICB commissioning stuff with neighbourhood models? Does the Advanced Foundation Trust status allow us to have a slightly different connection with the ICB in that respect?
I mean, the Integrated Health Organisation form is a contract form, not an organisation form, and that will need to be commissioned. So it is likely that that will be commissioned by the ICB. So therefore, that interface that the AFT gives us in that context is important. Yes.
Okay, thank you. That's made it clear. Thanks very much.
Yeah, thanks, Joe. And Dave and David, I believe that the way it looks as though is that if you go for the Advanced Foundation Trust process, what it doesn't do is guarantee the Integrated Health Organisation contract. But what it does do is puts you in very good position to be considered for that, and then that new neighbourhood ways of working and new commissioning approach. That's my understanding. Is that right?
Correct.
That was what I was trying to test, Faisal.
Yeah. So and again, I think Joe will be picking this up in the workshop next week, so there'll be a bit more clarification and understanding. So and it's a moving feast as well, because we're getting almost information on a daily basis with this as well. Dave.
Just on that, Faisal, I guess also the opportunity that we're going through allows us to move with partners, because we'll be sharing within the East Midlands Alliance, which we're part of. We'll be sharing our experiences, the process, helping people understand how they too can build momentum to go on a pathway towards Advanced Foundation Trust status and drive the population health models that we're describing earlier. So whilst it's individual to us, it's actually also an opportunity to move the sector.
Yeah, no, absolutely. And I think one of the things we said when David presented to us at the joint group workshop was that it really brings, beyond the badge that, Advanced Foundation Trust is, what it actually does is an absolute once in a lifetime golden opportunity to really address health inequality for a population group, which is, I think, the more important thing for us to focus in on. So a real opportunity. Thank you for that. We received the report from the Chief Exec, from Dave, for our information and clarification and discussion. And then we move on, Dave, with you, which is the NHFT's annual plan verbal update.
Thanks, Faisal. So as I say, trailed in the Chief Exec's report, we'll be able to bring narrative material through board in January and February. We're in a process now, a very tight process, to develop our technical plan, so some of our activity planning and some of our outline workforce expectations to go through for submission on the 17th of December. As I say, that will form then part of a full and final submission, which we would take through board in February of next year. So just to highlight, that's work in progress. We have an opportunity to review some of that in our private session this afternoon. And as I say, full kind of transparency and accountability in terms of the planning framework coming through board in due course, but tight timescales. And equally, we'll be engaging Council of Governors certainly in Q4 in terms of some of the narrative and the Thrive plan more generally, which we take through Council of Governors routinely in terms of our annual planning.
Thanks, Dave. That's very helpful. And as you say, we've got that on our agenda this afternoon, so we'll go through another bit of discussion on that. So very helpful. Any questions or comments for Dave before we move on? No? Okay, great. Thank you, Dave. And then we now move on into our integrated performance section on our agenda, and the first paper in the packs is paper G, and this is our alert, advise and assure report from the performance committee, and this is with Judith.
Thanks, Faisal. Good morning, everybody. I've written a more than fulsome AAA report for this cycle because we had a very rich agenda at the Performance Committee. So I just want to draw out a couple of things. Firstly, dealing with governance. So I seek approval from the board for amended terms of reference for this committee. There were minor updates following the effectiveness review that we have all had. And there were updates regarding group structures and titles, as well as the reduction of the number of NEDs attending from 4 to 3, which is generally aligned to a reorganisation of NED responsibilities. I also just wanted to mention under this heading that I'm not sure if there needs to be a board approval. It certainly had committee approval, that the health records management policy was updated and approved by the committee. Before I turn to the slightly more life realist approach of this report under advice, I really want to flip to the end of the report, if I may, to celebrate outstanding. And that's in relation to the report that we are soon to hear from, which is the Integrated Organisational Report. This report forms the backbone to the committee, and the non-executives as well as the executives use it to triangulate right through the entire organisation. I'm at loss to describe concisely how much the committee appreciates the continuous development and change that the report has gone through to match the national and local landscape, as well as all the changes that we have brought with regards to our new strategy. So we have an executive summary, which, because the report is quite long, has been very welcomed. The new strategy has been incorporated. There's been slides of transformation and partnership on the new NOF, and also the finance data is starting to also flow through. So I really just wanted to congratulate the team and celebrate the outstanding. In relation to another outstanding and celebration, which doesn't fall under, I didn't put it under here in this column in the AAA report, but I do want to draw it out. It is the clarity and the conciseness of the Urgent Care Board update. So Anne, you and your team, seriously, thank you. I did say this at the committee. I didn't put it in the AAA report, so I'm feeling mean, so I thought I'd mention it. Now, I'm afraid we'll get a little bit more realistic because I need to turn to the advised sections of the AAA. And unsurprisingly, in the majority, they relate to finances. With regards to the risk report, there was recognition that the Richards team is continuing to work on the corporate risks feeding up into the BAF. I know that this work is almost complete. I do take on board the comment that Joe made that if there is none to report, that it should say none to report, so make it clear. And there was also discussion as to whether the rule that only risks of rated 16 or above should be included, because there is potentially a real risk around the cliff effect of something dropping from a 15 to 16, and those are quite high ratings already, and suddenly becoming clear in it to Performance Committee when previously they were not. So there is an element of discussion and development to be had around that. Turning to the next item under advise, which is the financial performance in month 6. I don't propose to go into this in much detail. The headline figure is that the performance deficit at month 6 was 33,000 against a planned deficit of 38. We are shortly to be discussing the month 7 performance status in our private board, so I will leave that aspect of the AAA as read. Very interestingly, and this was a new aspect into the Performance Committee agenda, is we had Sachin coming to give us an update from the Medical Directorate with regards to his work in the Directorate around the value programme and other things. As you will appreciate, because of the long-term absence of Itai through sickness. Sachin has stepped into this position of having to draw up the plans and finalise the plans, and there has been some delay, and there is it is unsure, as he said, how much of the value programme the Directorate will be able to deliver by the end of the year. But his input into the Performance Committee was invaluable, and I thank him for attending. And the final item under the advice section is the medium-term financial plan, which we have also discussed at board workshop. So I don't intend to go into it any more detail because we didn't get any more detail than we've already discussed at board workshop. Really happy to answer any questions that you may have on that. But we will, just to say, be continuing to have different directorates coming to speak to the Performance Committee on their value plans and their performance plans. And I'm also working with Gareth in ensuring that not only the committee but also board gets more regular reporting on the group BAF around digital and technology risks. Happy to answer any questions. Thank you.
Thanks, Judith. Very comprehensive highlight from the Performance Committee, and I believe that you had a good discussion on and revised the terms of reference. So before we go to the decision on that, any questions or comments for Judith? No? Okay, so with that, if we can approve the revised terms of reference for the Performance Committee, colleagues all in favour of that? Yeah, okay, I'm getting nods. Excellent, thank you. And then, having said that, we then receive the AAA highlight report from the Performance Committee for assurance. So thank you, you and the Performance Committee for that. And then we're still in our integrated performance section, and then we're into the integrated organisational report, which is paper H in your packs. And Dave, I believe you're starting this with the other colleagues from the exec team.
Great, thanks, Faisal. So just to cover some key areas that are, and again, taking the report as read, we've obviously covered the Advanced Foundation Trust status, the planning, and I'll comment a little bit on Q2 results in terms of our expectations as we go into December and into the Q4 of next year. Just in terms of waiting times, our waiting list grew slightly from last month. 18-week standard, we have dropped to 91.9 against a target of 92. There's ongoing productivity work within pathways, those 7 pathways which are challenged, which we have some very focused work on. We're seeing good improvement across adult dietetics with 30% improvement, and CAMS initial assessments equally at a 66% improvement. So again, just to reassure board in terms of the work that's ongoing in terms of productivity and those waiting lists that remain challenged, there is movement within that, and we are seeing results from the interventions we're taking to manage the context that those services find themselves in. In terms of workforce, we are seeing an unfavourable sickness level against 66.2%, which is largely driven by winter effect or seasonal effects, but bearing in mind that our target going into next year is 4.1%. So that illustrates some of the ongoing context that we need to work with as we drive sickness levels down. In terms of workforce demand and capacity, our turnover, however, remains favourable at 7.4% against a ceiling level of 10%. So again, there is some flexibility within the model to allow that sickness to be mitigated, but entirely an unfavourable position, which we are working on, and indeed we commented on in our people committees yesterday. Vacancy levels are up slightly at 11.8%, and we're seeing good progress with mandatory training. Anne Rackham is helpfully also leading a piece of work looking at very, very detailed mandatory training across services to ensure that requisite training for particular pathways are on target, and we're feeding that through to the exec management board as a routine item. Quality and safety, positively, we're seeing good safety incident reporting. a percentage of those result in harm, which is mostly low severity. And again, positively, 92% of service users would recommend NHFT as a place to receive care. We have set ourselves within the senior leadership team in the trust to really double down on the friends and family tests going into next year as a focused piece of work for us as a wider organisational piece, so that we understand the drivers of what people experience when they come into the trust, both to work and to receive care, and then highlight areas that we can improve on as part of our development as an organisation and part of our planning into the 10-year framework. Finance, we're going to spend some time on, as Judith alluded later, and I think Judith's given a pretty comprehensive update in terms of the discussion we had there. Just focusing quickly then on our care delivery pathways. We've had our best length of stay performance in adult community services, with, well, in addition to the 10 beds, which I highlighted in the Chief Exec report, with 29 days versus a 38-day target. That is really, really important. Back to Judith's commentary about the urgent care updates that we receive through Performance Committee, that allows us to go into quite a pressured winter season. I think the NHS Chief Executive described it as, you know, possibly one of the most challenging we faced, with variants around flu and COVID, etc. So to have that level of headroom in our services is a real tribute to the team, and we extend thanks to them. Our COIP services, long waits persist in community paediatrics. We're seeing an improvement in the 18-week performance, with 20% versus a 28% national benchmark, which again is really positive. It remains a challenging area, and we continue to drive conversations within the system, and of course as part of the wider community paediatrics improvement work which the ICB are leading. We have also influenced some of the commissioning framework emerging from the ICB, with children's now elevated in terms of the planning, so that it's given the same status as neighbourhoods and elective care and urgent care, so that we can really as a system look at the wider opportunities for improvement within community peds. And ideally, as we head into the Advanced Foundation Trust component of our work, we would look to population health opportunities that community paediatrics offer us as an organisation, because that is, life begins in childhood. So it presents a really exciting opportunity for us to drive population outcomes in that space. But the here and now challenge for us as a trust is improvement in that 18-week performance. Equally, in our mental health and learning disability services, our out-of-area bed days have reduced. We're seeing, again, really positive improvement in lengths of stay. So 66 days compared to 89 at this point last year. That, again, is really, really positive improvement. The NOF, of course, the outcomes framework, does set out some expectations around length of stay in mental health services. So movement in that direction is really positive, and we benchmark very positively regionally, again, in terms of length of stay, with work to do. And again, thanks to the team for a very clinically and patient-led, with positive safety focus throughout that work. Our specialist secured services, we continue to see really great performance in reception screens. There are ongoing challenges in mental health assessments, which we are addressing, which are capacity related, but again, we're focused on those and we've got plans in place. So really good set of outcomes for this quarter, but again, some challenges in workforce, which we're aware of. They're unlikely to continue as we go into winter, but we have got focused work on it. And of course, focused work in terms of our finances, reducing temporary workforce utilisation, and a set of further control measures which we've introduced into the organisation in the past month. So I'll pause there, Faisal, and then just turn to my executive colleagues for any comments. Linda, in terms of quality and safety. I see Anne wants to come in, and Paul may want to make some comment publicly before we head into the private board this afternoon.
Thanks, Dave. Very helpful, very comprehensive, plus key highlights from your report. So thank you for that. Anne, with you first.
Yeah, I just wanted to just pick up a few operational bits. Really pleased around the length of stay in both areas. It's something that the teams have worked incredibly hard at, and is bringing some real benefits. I just wanted to mention on the adult pathway, there's a slight dip in the UCR performance. and that's around how some of the community work's been inputted. That isn't just because they've suddenly recorded differently. There is also an interesting part behind this. If we've been working on the continence pathways, in particular catheter care, as one of the main reasons people might be transferred to hospital. So in our work was coming back in the pathways of how we try and avoid admissions to ED. We've done some changes and some focus on that area, which has had some impact on recording, but that has seen quite a significant even early on impact on how many people are going to ED. So there's some good news behind the challenges of how we just put that right in process, but just wanted to highlight that. And just around the secure services, yes, the mental health is really challenging. And one of the things that I'm keen to do, I visited HMP Ramsey last week, I forget the weeks I'm in, and it's about learning from different sites, and they've got some interesting ideas and thoughts of some of the new prisons coming in. So we also want to learn from experiences of others around that area, and I think them encouraging a sort of a share and learn environment across the estate.
Yeah, thank you, Anne. That's really helpful in terms of providing some additional context. Paul.
Thank you, Faisal. And it's just to update further to the paper, and as it sets out, as Dave's just alluded to, we had a really busy month 7 for both bank and agency usage, and therefore month 7 was particularly difficult in terms of financially on the back of all of that. We did still present our balanced position for month 7. We've still got a gap on the value programme, and delivering all of our savings remains the biggest risk, as we've said throughout this financial year that it would be, and closing that gap is, as Dave's already said, one of the key targets that we are working through on a daily basis to be able to make sure that we can do that. So it's particularly difficult. We always knew that this last bit of savings would be stubborn, and it's proving to be so, but we are still forecasting break even by the end of the financial year.
Thanks, Paul. I'm taking from your comments there that we've got a good grip on to oversee the challenging bits of the finance, but we're still looking to deliver that break-even position.
Yeah, as far as grip is concerned, we've always had a really strong grip on what we're spending where. I think there's the more you drill down into the detail, of course, the more you find new opportunities for us to save money. But we've had 2.5 years of really pressured financial constraints that it's really difficult now as we start to keep looking for the next items. So when we set the plan back in April, we always knew that 6.5% savings was going to be a real uphill battle, and I'm sure there's all sorts of metaphors I could adopt at this point that will show, this last push is really difficult. That said, even at £21 million worth of forecast savings at this point, is still more than the organisation has ever delivered. So I think there's a bit of a balance there, Faisal, between we're doing all of the right things, we've got all of the right people looking in all of the right places. It's just a case of this last 1% is proving to be stubborn, as I said.
Yeah, no, I think we all, as the board of directors, recognise that, Paul, and I think a huge amount of plaudits and effort for all involved in all the directors and the teams to help support that process, which it sounds like you're getting that engagement from everybody, and you're absolutely right to highlight that it is, as is the case for LPT as well, that it's the highest that we've ever had to find the kind of levels of savings. So well done to everybody for trying to achieve that and going to our break-even position. I'll bring in Joe first.
Thanks, Faisal. Thanks, Dave and colleagues. As ever, a very comprehensive report. And Paul, you know, I do acknowledge the challenges on finance. I'm not sure it's going to get any easier in the immediate future, but you know, acknowledgement where, you know, give credit where credit's due. There's so much being done at the moment behind the scenes. So I just sort of pull out 2 or 3 strands, which, Dave, it may not be addressed to you. I've sort of cross-referenced, Tim, with your report from the People Committee, because I don't sit on that committee. So it may be that it's being done in there rather than needs to be exposed at board. But just the thing that jumped out at me amongst all of the data was just a number of different strands which sort of come together, which is that, you know, we've still got some fairly intractable problems on waiting times in certain pathways. We've also got situations where vacancy rates are increasing against a backdrop of lower turnover, which in itself is, you know, quite an interesting thing to consider. And then we've got sickness levels, which, you know, are being flagged again in your report, Tim, from the People Committee. And is there something amongst all of those different strands which we need to perhaps, you know, take a closer look at? As I say, Dave, it may not be for you, it may be a People Committee item. And I just, you know, it seems like a bit of a Gordian knot, and where do we snip into that to understand if there's any exposure to risk that the board need to be aware of? Thank you.
Thanks, Joe. Dave, did you want to come back in at this stage on that one?
I don't mind, Faisal, or we can do the round of hands.
Okay.
Happy whichever one you want me to do.
Yeah, let's get a couple more in, and then you can round us off. And if we we'll get to Duncan next.
Yeah, thank you, Dave. Really good and comprehensive report. My comment was on the waiting times. First of all, to acknowledge the really good work that's going on there. In particular, it looks to me, Dave, that you've previously reported on the focused work on the 7 service lines. And it looks like that's beginning to pay some dividends now. So first of all, congratulations on that. We still have, as you report, some really, really tricky problems there, including the over 104-week wait issue. And again, although it's probably too early for you to comment, but I think it is absolutely right that we point out for some time we've been saying actually this needs to be a system-wide response, and it was really good to hear in your report that children and young people have been stepped up as an area of focus within the planning. If you have any more to say on that, I think it would be, given it's such a big issue in the county, it would be worth just illuminating that a little more. But principally, Faisal, I was wishing to note that the progress is being made following the discussions we're having in board and committees.
Yeah, thanks, Duncan. Dave, did you want to come in first?
I can see Sarah's likely to come in on Joe's comment from earlier, and David on the CYP interfaces. But maybe if we do Natasha, and then we can circle back on it.
Okay, Natasha, let's bring in, and then we'll go to the responses.
Yeah, sure. So and maybe a little bit picking up on some of the strands from what Joe said as well. So first of all, I want to say it was an absolute pleasure to meet Janisa last week, and some of the work that her team lead on particularly on the data validation, the work that's being done across the trust on DNAs and caseload audits, and it's so important to making sure that the data is right in the system, and that those performance targets are being constantly monitored. So yeah, just a real thank you for the introduction. It was lovely to see the work that team are doing. My question really is more around, I suppose, the number of patients who are waiting less than 18 weeks. And again, I think we've got I think really good movement to what Duncan was saying in terms of the long waiters, but actually that body of patients that are waiting, and now that we know the planning guidance for the end of next year and the targets to hit there's actually, I suspect, quite a lot of patients sitting in that number that need to be seen if you're going to close that gap of hitting the performance metrics you're being asked of, the activity that will require, the finances that requires in terms of negotiation with the ICBs, and the staffing that requires. And that feels like quite a significant piece of work to be thinking about. And I really just wanted to understand is where that is being, I suppose, how do you start to eat into that problem? Because it's not something that you tackle in 1 month or two. It's probably a 3, 4, 5 year problem, and just be good to understand maybe a little bit more about the approach that's being taken there.
Okay, thanks. So Faisal, maybe if I go in with Natasha's and maybe ask Anne and Morgan to make some comments on the waiting list. I mean, I guess to say one of the things I think we can do, a bit like we do with our workforce metrics, is illustrate kind of what percentage of 18-weekers don't move within a block. So because there will be movement constantly and new patients coming in onto that pathway, and so we can have a look at thinking about how we could kind of segment that to give you some reassurance that there is good movement and people are moving in and out of that 18-week window. I'll have a think about that, Natasha, but I don't know, Anne or Morgan, if you want to make a comment on that specifically.
I don't mind coming in first and just to say that yes, so there is an incredible oversight into that waitlist position and trying to understand the movement on a singular service level, but also as a totality, because that's where you have to look at in the waitlist group. But we have signalled the need for a deep dive, so maybe we can look at though, like in the waitlist group for the professionals and clinicians around, so that maybe we can think about how we share some of that knowledge as we come through that will help in some way to meet your question, Natasha. Do you want to come in, Morgan?
Thanks, Anne.
Yeah, thanks for taking the floor first, Anne, because I just frantically counted exactly how many services this kind of applies to. So with this number of patients waiting less than 18 weeks, we're not talking about the full 123 service lines within NHFT. We're only talking about the 27 services that report into the Community Health Services SITREP. And I just quickly counted that's 18 adult services, of which 13 consistently meet the 18-week wait time standard. And that's 9 CYP services, of which 4 consistently meet it. So we've got a sort of a short list, Natasha, of services that we are working very individually with, because the reasons why they have waiters over 18 weeks are very, very individual, and the solutions are going to be very bespoke. As part of the planning round, we will be creating individual trajectories for each one that makes up the overall trajectory for CYP and adults, which actually gets submitted to NHS England. I can perhaps cover a bit more of it when we come to my annual planning update. But I hope that helps.
Thanks, Morgan. That's really helpful. What I would also suggest, Natasha, if you want to understand that a little bit further for your understanding, I would certainly advocate and encourage you to link up with Morgan outside of the board meeting and follow up, because I think that would also help your context and background understanding. If I bring in Sarah and then David, and then we'll go into Sachin finally. Sarah.
Thank you, Chair. So I will respond to Joe's very helpful observations around workforce and what the role of People and Culture Committee will be and is. So at our last People and Culture Committee, which I observed before I started in the Group Chief People Officer post, we talked about moving to a more detailed people dashboard aligned with one that LPT receives. So within that dashboard, which we're aiming to have come to next People and Culture Committee in its draft form for NHFT, there will be much more detail around sickness, around vacancies and around turnover in terms of tracking and triangulating what's going on in that space, because you're absolutely right. We need to have an understanding of if we've got lower turnover but increased vacancies, we need to really have a handle on what is that. Now, my information at the moment is telling me it's because we've got growth, i.e. secured services, staff trooping in. So the population of our workforce is getting bigger, and therefore that leads to potentially more vacancies. But we absolutely will need and will be triangulating through our workforce planning what the vacancy position is, why it's changing, and how it correlates against turnover. That's a really valid point, and we need to stay close to that as we move forward into next year's financial plan. So we really understand workforce movement, where we've got growth and where we've got activity. Other work that's going on at the moment and will be happening next week through various meetings with finance and the people team. We are undertaking another review of establishment reviews. So that will be working with all of our leaders to look at establishment and actually where we can potentially remove vacant posts in order to support our financial value programme of work. In terms of sickness, so there's quite a lot of activity going on in relation to sickness management and understanding why we've got sickness. The report that we've got in this pack today talks about refreshing the task and finish group for around sickness, which we will be doing, and I'll be looking to do some work across the group, the group arrangement around sickness management, because in both organisations it is incredibly challenging. We're not an anomaly as a trust in NHFT in terms of sickness. In mental health and community, sickness tends to be around the 5 or 6% in terms of benchmarking, but it is spiking in some areas, and we need to get underneath that and triangulate what else is going on in those services where we've got increased sickness absence, and are we doing absolutely everything we can to support the health and well-being of our staff. So we will be taking that forward, and that will come up through People and Culture Committee from the level 2 and the level 3 committees that are doing the work. Thank you.
Yeah, thank you, Sarah. That's very helpful to understand that. David.
Thanks, Faisal. I just thought it was helpful in thinking about the system response to CYP, just to share. I was looking back through our board papers in 2024 and just reflecting on the ICB Community Paediatrics System Review. And that was something that the ICB completed in October 2024, I think, or just before then. With then their views about how they wanted to take things forward and the changes that they wanted to make. So I think the ICB has then taken that into planning and been thinking about things. We are talking to the ICB at the moment about the opportunity for the system to develop a CYP collaborative, formally mirroring the MHLDA work and thinking about the lead provider functions and the range of different services. So all of that is feeding into current planning. And I think it is changing. And it was useful as I sort of reflected back over the last 12 months to think 12 months ago, there was a review into community paediatrics, which said things need to change. Where I think we are now is knowing that the ICB is very supportive of a collaborative, a way of working things together, and is going through the management steps of enabling those sorts of things to happen. So I think over the next couple of months, we'll see even more progress from a system ownership of championing CYP and taking that forward.
Thanks, David. Sachin.
Thanks, Faisal. So two things I want to assure people on. One is, I think, to say that myself and Morgan, all of us, we are working very closely so that everything comes into one plan along with the people's group also. And so that one can look at performance at any stage and have an idea as to where we will be in terms of performance, where we'll be in terms of finance, etc. So trying to bring everything together and probably, and we have done extensive consultation with the clinical group so that there is buy-in from people. moving forward. And we are looking at these lines which are beyond the 18 weeks specifically to bring the waiting list down. And hopefully, few of the more concerning ones, we should be able to bring it down in the next couple of months. The issue is everything is kind of interconnected with other stuff. So, for example, the CYP transformation, where that's taking us, I guess that's going to have effects on that. I had a conversation with ICB where they were asking about, for example, the IHA waiting list, whereas NHFT only has half the waiting list. The other half of the IHA waiting list is with NGH, but you know, there is more pressure on us on that, and yeah. So hopefully, moving forward, once there is the collaborative around the children and young people services, we'll move forward. Similarly, with prisons. As the prisons are coming on board, I think one of the things that we have to absolutely factor in that there were clinical issues present in these prisons, and we are taking them in and we are building them up. So, you know, that will reflect on when they come on to our books, they may come on with issues and we'll have to work through them. The issues won't be solved when they come on to our board. So there are a lot of issues that I think David and Dave are well aware of, and we are working through them slowly and in advance of us taking them over in the prison. So yeah, thank you.
Yeah, thanks, Sachin. That's really helpful to have some of that understanding as well. Dave, anything else before we close that section back from you?
No, thanks, Faisal. Morgan has joined, who's obviously leading the team that put the report together, and obviously we'll have missed Judith's kind of warm feedback, but we'll make sure that's cascaded through to the team to keep people feeling bouncy about the work that they do. Thank you.
That's great. Thank you very much, Dave. Thank you as well, Morgan, for joining us. Very much appreciated. So we received we're asked to note the report and receive that and review the performance, which we've done. So thank you very much. Very comprehensive. A really good discussion as well, Dave. And we move into our quality section of our agenda, and we're on item 12, which is paper I in the pack, which is the AAA highlight report for quality and safety, and that's with you, Julia.
Thanks, Faisal. So thanks, everybody. Bear with me because, as you'll see again, another packed report. We had, to steal Judith's words, a very rich committee meeting with lots of really important items. So I will just highlight a few of those if that's okay. There's nothing to alert to the board from the last committee, but you'll see the first couple of papers, we've got areas of ongoing monitoring around quality, and we're suggesting for the next meeting that we're going to strengthen our assurance with clearer mitigations and timeframes for those elements that are escalated from other level 2 subgroups that feed into the committee. So hopefully have some expansion on that next time. For the patient experience and involvement report, there's been technical issues with the new SMS text service that's been implemented on our system to gain feedback from patients and service users, and we do need accurate data, and a number of our people's responses were actually allocated to other organisations. There were no breaches of information governance around that, but actually we need accurate information, so that's being looked at. Wanted to highlight community engagement. It's the first time we've brought this to the committee. We have a statutory duty to evidence our community engagement activities with the communities that we serve. So we had an initial gap analysis against the NHS England statutory guidance, and we'll have an action plan coming to the next committee. In the Assure section, just wanted to highlight our deep dive assurance focus, which was on the first of our 2 NHFT BAF risks, and this one was around safeguarding. We were assured by the deep dive suggested some additional sources of assurance. And then, in fact, we had a bit later in the meeting the Safeguarding Annual Report, which is Appendix 2 that you'll see. And in fact, that then contributed to the overall assurance we took from this BAF, for this BAF risk. Wanted to highlight the intensive and assertive outreach across community mental health services, because we've brought this to you on a number of occasions as a board. This relates to the Nottingham report, and we've had an ICB review of our plans and our progress with our transformation services, and took really good assurance from the ICB review. But just wanted to add in that Anne Rackham and I did a whole day on Tuesday this week to our 5 newly reconfigured community mental health teams. They've gone down from 9 to 5. So we wanted to dip in and test out how staff are feeling, the effects on them and on patients, but also they've at the same time embedded the new Staying Safe from Suicide risk reduction framework. And we talked about that before. We had that at a quality and safety workshop recently that we highlighted to board a while ago. And in fact, most teams were transitioning really well. I think it's difficult with all change, but some were a bit further ahead than others, but we didn't pick up any significant risks with the transformation, and a great spirit of people understanding that this was all for patients, and patients will have better outcomes because of the transformation. So just wanted to add that in. There's then a couple of appendices. Appendix 1 is the Infection Prevention and Control Annual Report. I haven't done it justice here, as with the Safeguarding Annual Report. They're extensive reports, and we took significant assurance from them both against our statutory duties in these areas. Wanted to just highlight, bear with me, the Equality and Quality Impact Assessment overview. These are EQIAs. They're really important. They're a part of our governance whenever we make a change to services or to issues that affect staff as well as patients. And they also link with our value programme, and they test that we've thought ahead to the risks that might happen if we make changes. And for the first time, we had an oversight of the EQIAs that had been done this year. The most important bit for us is the next bit, which will come as some regular reporting, which is the impact post-implementation of the changes. And when we get that rich detail coming through, I think our assurance will be absolutely complete. Also just wanted to raise our annual committee effectiveness review, which is the terms of reference were reviewed as part of that. That's attached as Appendix 3, and some minor updates to updating to our new Thrive strategy, and a couple of administrative changes only for that. And in Appendix 4 is our committee workshop feedback. Had a fantastic workshop, thanks to everybody that input to that. And that covered restrictive practice in our mental health units. That's about restraint and seclusion, and our health inequalities programme. Fantastic oversight of that. Just a quick positive note, the update on the GP collective action. We've alerted to the board previously that the impact of the, I suppose, work to rule from the GPs in primary care was having quite an impact in 2 or 3 areas of practice for our services. There's been a lot of work across the system to try and negate that and to mitigate some of the tasks that they're not performing. The system-wide group's now been stood down for that, which is really positive because a lot of mitigation's in place. But in fact, Anne and I did pick up in our service visits this week with the community mental health teams, some of the issues with prescribing are still continuing. So I know Anne's going to take that through just to make sure that's fed back into the groups. On risk, I've explained we've had the deep dive on the safeguarding risk. We also had the opportunity to look at our second risk, which is around quality of care. And in fact, we have looked at the joint group risk that's assigned to us, which is around research and innovation. So we did have the chance to look at that, and we were assured by what we were seeing. We did put one caveat that, again, as I think Joe mentioned, some of the controls needed updating and some of the updates needed refreshing. So we look forward to that next time. Don't want to forget celebrating outstanding, some amazing pieces of good practice to report. Absolutely wanted to highlight the Allied Health Professionals Conference we had that Linda led. Fantastic opportunity for people to meet and network. And just The verbal updates and the additional information are at the bottom of the pack. So I'm sorry there's a lot there, but we covered a lot and wanted you to have full details. So happy to take any questions. You did.
Yeah.
Oh, sorry. Very Faisal.
That's all right. Thanks, Julia. Very comprehensive update on quality and safety. You did.
Thanks, Faisal. Julia, I have no idea how on earth you managed to listen, discuss and get assurance on all of that. I mean, I was just reeling, but yeah, fantastic. I've got 2 questions, both from your appendices, just to show that I've read them, but also because I'm actually interested in the answer. One's around infection control. It seems that the clinical practice audits are throwing up some quite low results and low outcomes, which is obviously of concern, but specifically of concern because potentially of the time of year we're in as well. So don't know whether that was expected, whether that's normal, or whether that was something that you discussed at committee. And the second question is around the safeguarding report. I had a couple of community service visits recently, and of course, safety of staff, physical and sexual safety of staff always comes up in community service visits. So I was just wondering, I'm totally aware of the Sexual Safety Charter. What I'm not aware of is what information we are receiving. I presume it's all going to QNS, but it'd just be nice to get a little bit more information around that. Are we for instance, data being reported by our staff, or actions being taken, lessons learned, etc., etc. Thank you.
Okay, you want to come in, Julia?
Yeah, thank you. I might bring Linda in actually on the clinical practice audits. Certainly for the sexual safety charter, we did receive a while ago the charter itself and our commitment, and I think we brought that to board, and we are responsible for the ongoing implementation. I haven't actually had an update on that, but I'll look to either Richard or Linda. Our work programme, I'm sure, has got that on it, but I might bring Linda in, if I may, Linda, on the clinical practice audits. We didn't discuss them specifically, but we do have regular updates on them. But could I pass that to, just invite Linda to comment?
Yeah, thanks, Julia. Thanks for your questions, Judith. So with regards to our IPC audits, these are carried out regularly, and some of the things that then come up will be to do with so if you go into an area and then it doesn't score in a particular section, then it really drops the score. But we monitor that through our weekly triangulation. So where things aren't where they're supposed to be, we quickly mobilize and do that work so that by next week we've addressed it. Our IPC team are very flexible. They'll revisit, they'll make sure that those actions are completed. So it's one of the areas where if we're seeing low scores, it's addressed immediately. Where there's been delays, which you'd have seen from previous reports, is where we're waiting for something to happen with regards to states facilities, and then that's picked up. It's discussed in full in the IPC group meeting, which then reports into our quality and safety assurance group that reports into quality and safety committee. So we do cover that and actually spend focused time on it. With regards to sexual safety, we've got a plan that we're working to in line with the principles that were outlined by NHS England. So that work is done through our trust-wide safeguarding group, and ICB colleagues sit within that. That group then reports into our quality and safety assurance group. So what we've tried to do with QSAG is to have that as the space where we are discussing all these operational issues, and we then utilize that to alert, advise, or assure the committee. So where Julia was saying that we're now strengthening in areas, that's one of the areas we are strengthening so that the reporting is really clear and it supports what is actually happening within services. So if we are identifying a risk, is it mitigated? Do we have robust plans in place? What is the issue? And is then asked from committee. So those are some of the things that we're now going to be bringing forward within our reports, because we know it, and then we don't always write it in the way that our audience will best understand it. So absolutely, we've got those plans, and it's covered through that group and has been reported as on track to Quality and Safety Committee. So the information will go through to them yet again, because we've built in those regular updates.
Thank you, Linda. That's really helpful. In respect to infection control, I've been on service visits with you. I know you do this, so I'm totally assured around that. And on the just on the sexual safety charter and the data, do you have a timeline on when it's expected that QNS will start receiving slightly more detailed reports? We can take that offline. It's fine.
Yeah, I think that would be helpful. But thank you, Linda, for that. I think that really gave us a good understanding of where things are on the audits and dates. Joe.
Thank you, Julia. I'm going to take us to one of the appendices as well, the safeguarding report. And it's just really to put a flag on an issue which has been rolling during my time here. And it's the Northamptonshire Cared Record and the fact that we are still in a position where data isn't shared consistently across relevant agencies. And I know that colleagues are working really, really hard on this. But I do think that as a system, in order to get things working as they could do, and all the work that David Williams and Dave Mayer are doing in that partnership landscape, this underpins all of that work, and having an effective data platform that all of the system partners share is absolutely vital to future success. So I'm not saying it's necessarily a massive issue at the moment, because I know colleagues are working hard on it, but I think as a board, we need to recognise that deficiency. Thank you.
Yeah, thanks, Joe. Did you want to come in on that, Linda, before I move to Anne?
Yeah, so I just wanted to come in to provide some assurance with regards to that. So where we say it's not being shared consistently, it's to do with the systems that other colleagues have. So we still have in health, as you'll appreciate, paper records where others are now on electronic records. So that then creates a timing issue, as you'll appreciate, in emails being sent across, which is very different to logging into a system. So this is one of the areas that we are working on across the system, and we've started to see where it's working. So like our respect forms, those now are going onto that digital platform, move around with the patient. So there is work and progress being made with regards to that. Thank you.
Yeah, thanks, Linda.
Thanks.
You know, from a future life, I understand the complexity of this, but it is absolutely vital that we just keep it in our crosshairs for future reference. Thank you.
I don't think there's any doubt it's in our crosshairs, Joe. I think everybody on this in this board and across the organisation is absolutely on it, but we absolutely understand the challenges also that it creates. But yeah, I think, Linda, the assurance that you've given us, that's really helpful. Thank you. Anne.
Yeah, I just wanted to also share that QNS gets reports from health and safety, which includes our staff safety group. So the wider sort of any incidents that relating to staff, which will include the sexual safety as well. We have that as an standing agenda item, just so that that connection is also linked in.
Thanks, Anne. Good to understand as well. Sachin.
Yeah, this common record, it seems to be an ongoing saga. Totally agree with Joe. I see, you know, I've been going for meetings, but I guess the problem is really in getting all the systems to agree and talk to each other and bring them to the same platform. And I don't know if you've been to UHN recently, but if you go there, they don't look at your records electronically. They have a paper copy on their table, which they look at when they speak to you. And that is, yeah, I'm not going to say anything more than that. But yeah, but we are making good progress.
I think you know the complexity of these things, and I know what there's a lot of work going on behind this, and the challenges that it presents as well, Sachin. I think
we are hoping that there's a kind of sum of money coming, which will update the UHN records, and then we'll be able to integrate quite easily with it at that level. Yeah, thank you.
Yeah, thanks, Sachin. Dave, did you want to come back in?
Just so that the board is we can segment the opportunity that Joe's highlighted. One is a better information exchange and support for patients in a timely sense, and then that is related to but separate to the overall risk management and safeguarding oversight that the system has, which I don't think there's a suggestion that that's necessarily diminished. So just to make sure we don't conflated too, because we're not exposed to that kind of risk at the moment.
Yeah, no, I think it's good for you to highlight that, Dave. I think the issue is that we're talking about the sharing and make the efficiency and effectiveness of getting that information if there was a shared care record. But what you highlight is that we're not diminishing the safety of patient safety, sorry, in that context. So thank you for that, Julian. Thank you, colleagues, for the discussion. Julian, we've got the terms of reference. Are they? Have you reviewed those at the Quality and Safety Committee? Are they for board approval? I'm guessing here.
Yes, please.
So first of all, can we approve those terms of reference as revised by and reviewed by Quality and Safety Committee? Colleagues happy to approve? Yeah, great. I'm getting a few nods. Thank you. Yeah, I'm getting a thumbs up. And then we've received the Quality Safety AAA highlight report for assurance. So thank you very much, Julia, and to all of the colleagues on that committee. And then we move into in your agenda, PACS paper J, which is the Patient Safety and Learning Assurance Report. And this is with you, Linda.
Thank you, Chair. I will take the report as read, and I'm mindful of the time. So I've just got a few areas that I'll highlight to board. So the first issue I'm highlighting is with regards to illicit drugs and alcohol within the prisons. We've seen an increase, but that's now starting to reduce with specific prevalence of the drug spice. This continues to be monitored, and actually we're now starting to see that downward trend. I also then wanted to just highlight to board around the work we are doing with regards to pressure ulcers. These are the ones that will have occurred to patients who are receiving services from us, or the pressure ulcer has since deteriorated. So we've got a pressure ulcers review group. We've also got some excellent peer reviews that are being done across the areas, and actually the work that's going on with regards to that, a lot of learning coming out of this, and we will then be able to share this work as part of our quality improvement with Quality and Safety Committee. So that's work that's underway. I did also want to just mention that with regards to our incidents that we are reporting, or the falls are one of the categories that we do see as a high priority, i.e. we do have a lot of falls. These are always reviewed by our falls lead, so we immediately take any learning, any preventative actions are looked into, but I'm pleased to report that we are not reporting any with moderate and above harm, so most of these will be low harm and being well managed. We also look at this with regards to the next report I'll present in workforce monitoring, workforce safeguards. So we link that if there's been a fall while staffing, a contributory factor. Again, we've not identified it during this reporting period. What I'd like to then sort of highlight to board, and you won't be aware of this, Chair, but this did come up at a previous session with the board around the question of our engagement with families and patients when there's been incidents. So just provided a summary on that work and what is being done by the team, which I hope you find useful, because that then answers the questions which we had answered through Quality and Safety Committee, but useful to then reflect it here for the board. I will end off by asking that the board is assured with regards to our processes and how we are managing risk insofar as our patient safety incidents. There is no decision required of board, but I'm presenting this paper and happy to take any comments or questions. I also want to assure Trust Board that this report and subsequent reports that come alongside this will have been reviewed within the patient safety group, and that meeting was held on the 21st of November. Thank you, Chair.
Thank you, Linda. Really very good quality report to read, very clear to follow as well. So thank you to you and the team for the report authors for that as well. Questions, comments? Julia.
Thanks, Faisal. Not a question, just a comment. I just wanted to highlight Appendix 2, which is the Learning from Deaths report, because we don't get a separate report to board on that really important area of our governance. And there's a really good section with identified learning and actions and some good practice examples. And just wanted to commend that because there is a really thorough process behind all of this. And I think we just need to make sure that that's we shine a light on that because it's really important area of practice. Thanks.
Thanks, Julie. Thank you for highlighting that as well. Anything from any other colleagues? No? And then in that case, we take a high level of assurance from the report presented by Linda, and to ensure that all the processes and procedures in place for patient safety at the board takes level of assurance from. Thank you very much. And then, Linda, we're still with you. This is paper K in the pack, which is the Monitoring Workforce and Safeguards report.
Thank you, Chair. Again, I will take this paper as read. Just to highlight, some colleagues will be seeing our registered nurse vacancies, and those will appear to be a lot, but it's a mixture of things why we've got those numbers. Some of it will be we've got staff who've been promoted, and actually when we've mobilized into other areas, there's opportunities for other staff to then develop, so we then end up with some gaps to fill. It's also around flexible working requests, which we see a lot more often, where you will have in different areas some staff reducing their hours, but when we then report this, it equates to a whole-time equivalent and not necessarily a whole post for an individual in a team. So great that we're supporting staff that way, but then it leaves those little bits of whole-time equivalent that you can't readily recruit to. So we then have our workforce planning group who then look into how that can then be skill mixed to then develop our new roles. So some of this will be the establishment that we then use to create the new roles that we so very much need within the organization. Provided more information with regards to our medical staffing. This is something that we previously did not bring here, but we've now brought it together within one report. It was reported in other reports previously, but useful to have it in the same report and look at it from the lens of how staffing impacts on our service delivery and the quality of care that we are providing. What I did also want to highlight within this report is with regards to professional registrations. So with regards to our nursing registrations, medical, as well as for our health and care professionals and pharmaceutical, I'm pleased to report that we're not reporting any lapses in registration. Where we have had colleagues in nursing where their registrations were coming up to lapse, there's been extensions agreed and they'll be able to meet those. So we are not reporting any lapses at this stage. I then wanted to highlight to board with regards to our multidisciplinary staffing considerations. So you won't be aware, Chair, we've previously discussed around our establishments, and actually when we start to look at our fill rates, whilst it might look like we had less, say, registered nursing, healthcare support worker, we then rely on that multidisciplinary staffing consideration because that is what then supports us to meet the care of our patients safely. So that could include some of our therapy colleagues then running groups with those patients. It could include some of our ward matrons stepping into those nursing numbers. So it's useful to then present this to board so that colleagues have a wider understanding. As I've said for a previous iteration, we know it, so we take it for granted, we've answered it, but actually other colleagues will not be cited to that. We also then look at our staffing with regards to bed occupancy. So you'll find that when the occupancy numbers are low, then actually we're not just going to readily fill that position if someone, say, has gone off sick at last minute, because actually the team are able to cope with the patients that they have and the level of activity that they have within those areas. And we then provide those explanations within our fill rates. We've looked at day 6 incidents so that we can check and be assured whether or not staffing has had any contributory factor with regards to that, and this is included within the reports. We've conducted our establishment reviews, and actually, again, we are assured with regards to our establishments on our wards that actually we are meeting the needs of patients safely within NHFT. What we've also then been able to do with our teams is that our safer staffing team, matron, they're very much involved with the EQIA process that Julia mentioned in her report, so they will review any sort of changes that are being proposed with regards to impacts on staffing. So it all comes together when we look at it from that perspective. I've also provided you with the appendices that are the unified report, as well as any risks that we've discussed within the monitoring workforce groups, together with the establishment reviews that we've completed. This is being presented for information and actually to mention all the work that we are doing with regards to monitoring our workforce safeguards. I'm happy to take any comments and questions, Chair. Thank you.
Thank you, Linda. Again, a very clear paper. Thank you for highlighting some of the key points from within the report. Tim.
Yeah, just quickly, two things. Firstly, Linda, the establishment reviews, which we've touched on before, are really outstanding, and it really gives me some good assurance that actually this isn't just about the numbers themselves, but it's how they land on the ground and the teams, the patients that they are supporting. So well done, thank you. And it's something we've touched on before. It's just a governance issue, probably for Richard. Is there's a slight lag because of the nature of the committees these papers go through, and then they end up here at board. It means the graphs we're looking at in this document are different to the IAC report. And so things like vacancy rate, which looks okay in this report, blips out in the IAC report at the beginning. So it's just for us as a board, we need to be aware of the data we're actually looking at rather than what's being presented potentially. And just come straight back.
Yeah, come on, Linda.
Yeah, so what I've done is in the background, I was having an email conversation with Sarah around how the reports are being presented, because when we've made changes in here, then the dates of meetings are off kilter, but absolutely we will address that in the next financial year, Tim, so it should align going forward. But a really good observation, and apologies for that. It's just when we've changed how the committees were configured, it then meant that the meetings we already had with colleagues, really difficult to change those. So it's something that we are working to so that it is aligned and we're reporting the same reporting periods.
Yeah. Great, thank you, Linda. That just shows that we as a board can take a high level of assurance that you're already over this and you've picked it up. So thank you for that, Tim. Any other questions before we move on, or any comments? No. Okay. Thank you, Linda. So we take the report for information and we note that. Thank you very much. And then we move on to our people section, and it's with you, Tim, the people committees, cultural committees, alert and advise and assure report.
Yes, so like everyone else, I'll take the report as read, conscious of precious time. There were no areas in the October committee that were flagged as alert. There were a number in advise on the workforce dashboard. At the time we went into this, everything bar sickness was within target. I'm conscious that vacancy rates has, as Joe flagged earlier, have moved since this report was done, or since the meeting at least. There was a really good update there on secured services, which gave us confidence that we are heading in the right direction, although not there yet. The temporary staff report, which is a shift from where we were historically. We used to just report on agency spend. We now report on agency and bank, which puts us into a net negative position, which has been picked up elsewhere, but we are just flagging that we're tracking both of those areas. And then the reduction in priorities across the Midlands temporary staffing programme was a good update, established the protocols, and shows a good discussion about the bank reductions that we're targeting to make. The rest of those I'm not going to touch on, apart from Guardian of Safe Working, where there was examples of where breaches need to be flagged better. So there's a review going on in there at the moment. We were confident that we have it all tracked, but we just want to come back with some work, so that's good. and then good assurance in all other areas of the discussion. It was a lengthy meeting, but there were some areas of outstanding which we just wanted to flag, particularly the work going on around valuing our people management group and the organisation design work. So the changes that are happening across the people services within the teams. And then the annual voluntary service report, which was an outstanding presentation and really showed a lot of the work that's going on in the community and being done by volunteers across NHFT. So excellent. Thank you.
Thank you, Tim. A very clear report, and thank you for highlighting some of those key points on the report. Judith.
Thank you, Tim and Faisal. This isn't a question, Tim, you can relax. This is a comment, which is, it's really interesting. And you know, I'm learning a lot from all the work that I'm seeing around bringing the two NHFT and LPT people committee into a group model. So I'd like to, you know, thank the team that are involved in that, because that they don't know, but they're providing me with a learning curve. So thank you.
Yeah, thanks, Judith. I think we would all endorse that comment and support it, and the hard work that goes on behind the scenes to bring all of this together. So thank you, Tim. So we received the AAA report from the People Committee for Assurance, and then we move into our governance and assurance section, and we've got in your PAC's paper M, which is the annual effectiveness review of the board and its committees. And this is with you, Richard.
Thank you, Faisal. So yes, paper M presents to the board the outcomes of this year's exercise. We concluded the review of both board and committee effectiveness last month. And as board members will know, we had the opportunity to discuss this at our recent board workshop in October. I've included, just for as an aide-memoire really, the details of the process that we followed, given that we agreed this earlier in the year, and a summary of the results in the body of the report. It's worth noting that actually, as far as the individual committee results are concerned, detailed discussions have been happening in committees over the individual results. So I haven't added too much detail on those here. Instead, I think in the interests of time, it's probably worth drawing board member attention to the proposal concerning improvements to the governance administration of the board, which you can see on, I think it's the third page of the report in the proposal section. Again, we had a discussion about these in the board workshop, so hopefully these are familiar. And we can see here that we're proposing to work not just within NHFT, but across the group to implement a new template for board and committee reports, building on the changes we've already made to make things easier and clearer both for board members and indeed for members of the public that might be consuming our materials on our website. We value the added richness that we gain from supporting papers, but felt that actually introducing a reading room or background papers could help segment some of the most salient content from the main pack of papers, and therefore include that in a reading room. And as we've alluded to already, with further alignment between NHFT and LPT, we will continue to align the work of board and committees across the group so that we can essentially maximise the efficiency and indeed the effectiveness of our work and reducing the administrative overhead. So hopefully those are familiar from the discussions that we had at the workshop in October. Really, I'm just seeking the board's endorsement of those three areas for the board. Of course, the individual areas for committees are here more for information as they are committee matters. But I'll happily take any comments or questions on the report and seek board approval for those 3 points. Thank you.
Yeah, thank you, Richard. And certainly, I think, again, really helpful to understand the board effectiveness and the proposals. Incredibly sensible to align that as we kind of work together. And I think taking high levels of confidence from the report and the surveys done, that we're all in the high 80s for board effectiveness and all the committee effectiveness, which I think is, I know a number of organisations, speaking to chairs across the country, that they'd be very pleased to receive those results. So thank you very much for that. Any questions or comments for Richard? No? Okay, lovely, thank you. So we've got the proposal before us. So we received the outcomes of the annual effectiveness review, and colleagues happy to endorse the proposals for improvements as outlined in the proposals in your papers? Yes. Okay. Lovely. Great. Thank you very much. I'm getting thumbs up and nods. So, Richard, you've got the proposals approved and supported. So, thank you very much for that. And then we've still with you. Sorry, no, it's with Sarah now, your Group Director of Chief People Officer role. The annual report, which is paper N, which is from the Remuneration and Nominations Committee, which is paper N.
Thank you, Chair. So the paper provides oversight of the 8 meetings that have taken place since the last annual report, provides oversight of the work that the Nominations and Remuneration Committee have considered during that period. So just asking board today to receive assurance on the work that that committee has undertaken, please.
Thank you, Sarah. Any questions or comments for Sarah on the report of the Remuneration and Nominations Committee? No? Okay, lovely. So we're being asked to confirm that we're assured by all the matters that are being considered by that committee and they're appropriately resolved and effectively. Happy to support that. Yeah, I'm getting nods. Thank you. And a few thumbs up. Thank you very much. So thank you very much, colleagues. And then we move on to the Alert, Advise and Assure report, which is from the Audit and Risk Committee held on the 18th of September. This is paper O in the pack, and this is with you, Duncan.
Thank you, Faisal. Happy to say we had no items for alert and approve. On advise, we once again received a report on the usage of waivers, which was a bit higher than we would ideally like to have. And we have therefore asked and been assured that the Strategic Exec Board and Exec Management Board were going to take a bit more of a deep dive into this, and looking forward to next time's report and see how the progress is. It is a tricky problem to get into, and I'm confident that the right level of input in the organisation is being had there, as was the board, the committee itself. Under Assure, we received number of updates from TIA. TIA are our internal audit advisor. First was on anti-crime service provided to them. That's including the fraud work. First of all, they had conducted a review on our behalf of our compliance with the Economic and Corporate Transparency Act 2023 and found that we were largely compliant. There is a little bit of policy work yet to be done to get that up to full place where we're fully compliant, and we'll be keeping an eye on that through the committee through the rest of the year. We also had a discussion about awareness of anti-crime and anti-fraud behaviour, and the received assurance that we're going to attempt to build that into the induction programme. There was a debate about other training, but that was seen as being overladen at the moment, and induction seemed to be the most appropriate place for executive colleagues to take that forward and have a look at. TIA also provided us with an update on where we are with cyber and the cyber assessment framework. Essentially 2 pieces of work undertaken here, which are giving the board assurance. The first was a report which was positive in its review of the data security and protection toolkit. And the second was taking a look at the outputs of the recent multi-agency strategic level exercise, which took place across LLR. Once again, this is an area of Assure. Further assurance was received on data validation, in particular with the early intervention psychosis team. I'm pleased to say that whilst there were 2 important and 5 routine actions identified, by the time of the meeting, they had all been implemented, which was really good to hear. And whilst there was a data gap, some missing data due to some software version changes, as I understand it. That was quickly picked up following the audit or during the audit and has now been corrected. Tia also gave us a report on planned preventative maintenance within the estates function. Now, as an old hand and having had a career in the executive line, including work with our estates colleagues, this is a really tricky area to get to grips with. And I was really, really pleased that our internal audit colleagues acknowledged that. They do a lot of work elsewhere and they could see that that was a problem. In the past, our trust has had a limited assurance in this area, and it was really pleasing for the committee to welcome an upgrade on that with a clean bill of health essentially being given for the estates team on what they're doing there. More to do, but really good progress, and congratulations there. We had updates in terms of summary internal controls assurance and from our external auditors. At this stage in the year, they're more just updates to see how we're going with those two processes, and they were very positive and provided the committee with assurance. And then finally, we had updates on the BAF, which we have debated here at this board meeting, and on the Data Use and Access Act. Let me finish on the high note of celebrating success. It is not common, in my experience, for an internal auditor's report to be able to come back to an audit committee and say that all the recommendations have been implemented and we're all up to date. We should be clear that that's unlikely to hold steady all the way through the year, but it is I would suggest to the board as chair of audit committee, it is a clear indication of the culture and the seriousness that our organisation takes these reviews, these reports, the way that we look at them, that for the second time running, I'm able to come back to this committee, to this board, sorry, and report from the committee that we have all our recommendations up to date. To be clear, I think it's remarkable that we've done that on 2 reports on a run. I'm not entirely convinced it's going to continue forever, but I think it really is a great indicator of the work of the executive team, senior management colleagues, and colleagues across the trust. So with that, I shall polish off and say thank you.
Yeah, thank you, Duncan. And I think what you've done is you've set a benchmark with the teams to continue that trend now, Duncan, because we won't be expecting anything less really from you going forward. Do you want to come back in, Duncan?
Apologies, pressed the wrong button.
Oh, no
button
problem.
chaos.
No, thanks, Duncan. Again, I think some really good highlights from a very comprehensive AAA report. We take high levels of assurance and some of the excellent work that you've highlighted, and some very positive trends and positive work from the internal audit as well, which is really good to receive and read. Thank you, Duncan. Julia.
Thanks, Faisal. Yes, thanks, Duncan. Just 2 comments. One is the point you just made at the end about the outstanding situation around actions not being, being completed and not outstanding. That is absolutely phenomenal. So I just wanted to add my congratulations to everybody. It takes a huge amount of effort. But I also wanted to come back to the planned and preventative estates maintenance. And just to say, I remember from a few years ago, from the previous audit, where the Quality and Safety Committee actually tracked a lot of the actions, because they had direct impact on patients and staff, and to come back and find an improved situation on that is again a really worthy situation. So thanks to everybody involved in that from patients and staff point of view. So thank you.
Thank you, Julia. And Natasha.
Yeah, and I just wanted to again from the performance workshop we had recently on digital as well. I think we also heard some really nice reassurance around the cybersecurity element as well. It's nice to see that across the committees as well. Elements like the update of Windows and the getting onto the NHS CCOS cybersecurity system as well. So some other elements there, and actually I think really positive that that cybersecurity event that was staged has really shown a lot of learning that the trust is taking forward. I think that it's absolutely the reason why you do emergency planning and response, and I think it's really important. It's you know, I think Dave said it at the previous meeting, it's probably one of your biggest worries. So I think just really positive to see a really proactive approach to tackling that on many levels.
Yeah, thank you, Natasha. I think that everybody on the board would support that those comments as well. So thank you. Any other comments for Duncan or any questions? No. Okay. Thank you very much, Duncan. And so we received the report for assurance from the Audit and Risk Committee, and then we move to items for information, which is paper P in the pack, paper P in your packs, which is our board declaration of interest register. Always, please, colleagues, if you haven't recently updated those, always please check those to make sure they're always updated. You can access those through the corporate governance team to make sure that they are checked and up to date. I'm not expecting any comments or questions on that unless anybody has a burning desire to raise something. No? Okay, great. So we'd note that for information, and then we move into any other business that we've I've not been advised of anything in particular other than which we covered very briefly, that this is Melanie's last meeting as a non-executive director, and she then goes into from the next public board meeting of the directors of NHFT on the 1st of January as an associate NED. Melanie, just for your information, that doesn't mean you can relax and do less work. It absolutely does not mean that at all. If anything, we'll be working you harder as an associate NED. So just in case you had any plans to do anything extra with your free time, there's none of that happening. So just but a huge thanks from everybody for the work you've done as an non-executive director. I've got a couple of hands up. Paul, first with you.
And I wonder, Faisal, whether Sachin's going to say the same thing as I am. I can see he is going to say the same thing. So just so that, and I think everybody's aware of it, but I think it's worth repeating. Sachin, along with Simon Harris, was at the HSJ Awards last week and was there in person to pick up the HSJ Award for Collaborative of the Year for the CAMS Collaborative, which NHFT hosts on behalf of the rest of the East Midlands. It's richly deserved. So I was kind of sat on the presentation that Sachin gave to HSJ at the time, and even though I've heard it a few times, Sachin, I'm never failed to be impressed with what's been achieved over the last few years by so many. We've made such a difference to children, young people and their families. We are delivering better outcomes. We are spending less money. It is what the future of the NHS needs to look like. So I just wanted to pay tribute to everybody within the CAMS Collaborative, Faisal, for that, and many congratulations to them.
Yeah, thank you, Paul. Thank you for highlighting that. I think the point that you make there, whilst these recognitions and these awards are very good to receive, it's actually what message they send, why we receive those reports. It's actually about the people, the cohort that we serve, and the outcomes for those people that we serve in our communities. It's a recognition of the work we do. So well done to everybody involved. Sachin, if you'd be kind enough to convey a huge thanks to everybody in the collaborative to make sure that there's a real appreciation from all of us in the board of NHFT, but the whole organisation, but collectively in the collaborative and that wonderful collaborative work that takes place. If I could just bring you back in, Sachin, before I go to Judith.
Yeah, thank you, Lord Faisal. So, yeah, I think it was fantastic. We were not expecting to win this at all. So it was fantastic to win it, yeah.
No, absolutely. And we shall revel in your glorious sunshine of winning the award, and we will continue that for some time to come. So well done to everybody. Judith, final point from you.
Yeah, thank you. Sachin, it actually goes to your absolute professional modesty, what you've just said. So double congratulations to the team. But I was going to say, Faisal, you are 100% welcome at the Trust now. You've finished chairing the first board meeting. So well done and welcome again.
Oh, well, thank you, Judith. We'll go on to the next bit because it'll be part of the judgment call of how well or badly I've done. So this is where you have the opportunity. I guess just as a snapshot of the board performance today, I mean, we've had an effectiveness report, but that was before I arrived. So really just thinking ahead, and do you felt the items that we consider the timings were appropriate? Always please relay those back to Richard. Certainly happy to come back to me directly as well. And if there was anything you felt that we could have or should have covered on the agenda, I looked at the work plan and everything that we were meant to have at this month's board meeting we received. I didn't make any notes of any other additional risks that we need to highlight in light of the discussions we've had today. Did anybody else spot anything that they wanted to feel they needed to cover in the risks that we haven't already captured? No, I'm getting shakes. That's good. And are there anything key things that we need to disseminate across the trust? Well, I mean, the HSJ one, I think was already, we've got some comms already out with that. So that's, I think, already happening, which is really good to see. And again, if I can use the chair's prerogative for this one, I felt the papers were incredibly clear, concise. I thought there was a lot of really good information in there. There was a really good understanding of what the issues are, what the analysis of those issues are, and what are we doing about them, and what else is in train. So that was really very good. So it's really good to see those. And I think throughout our discussion and we set the board meeting up with the presentation from the Secured Services, which I think really went to the heart of addressing inequalities, addressing health inequalities, greater outcomes for that population group, which was great. Anything from anybody else? Julia.
Thanks, Faisal. No, I just wanted to say thank you. Great chairing on your first meeting. Really agree with all of those points. I was going to come in on the patient staff story. Absolutely phenomenal. And I'm really pleased you let that run, because we got some really useful information about that out of the continued sort of extended discussion. And I think you're right. It sets the tone. That's why we're here for the whole board meeting. So thank you. Well chaired and a really great start to the meeting. And I suppose it's a thing for the future, really, isn't it? That we don't cut these stories short, because actually we get so much really good, productive information out of them. So great. Thank you.
Yeah, no, completely. I think everybody would endorse that, Julia. I think I just thought, particularly personally, from a personal level, having not been involved in LPT with Secured Services, because it was really very illuminating. And I think I've already received emails from colleagues from Secured Services inviting me along to a visit here, there, and everywhere. So it's trying to fit them as in. It's going to be the interesting bit. So no, it was very good. So